पैलिएटिव केयर देते हैं। इसका बेनिफिट कहाँ कहाँ होता है? इसका बेनिफिट जो होता है वो अननेसेसरी हॉस्पिटल एडमिशन को प्रिवेंट करने के लिए होता है। ठीक है, अगर आप जैसे पैलिएटिव केयर प्रोवाइड करते हैं तो पेशेंट को भी, क्योंकि पैलिएटिव केयर में व्यक्ति क्रॉनिक टर्मिनल इलनेस से सफर होता है तो उसको एन नंबर ऑफ सिम्टम्स और क्लस्टर ऑफ सिम्टम्स देखने को मिलते हैं। जैसे अगर उसको पेन हो रहा है, डिस्निया हो रहा है, वॉमिटिंग हो रहा है और बाकी बहुत सारी चीजें भी उसको एज पर द डिजीज कंडीशन हो सकती है। तो वो अगर आपने पैलिएटिव केयर सही समय से प्रोवाइड करना शुरू किया है तो उनको अननेसेसरी हॉस्पिटल एडमिशंस को हम प्रिवेंट कर सकते हैं, विजिट्स को भी प्रिवेंट कर सकते हैं। नॉट ऑलवेज द इंडोर पेशेंट, इंडोर पेशेंट के तौर पर हम उनको एडमिट करने की आवश्यकता होती है, पर हम आउटडोर पेशेंट के तौर पर भी उसको कर सकते हैं। Sorry, it can be given at the home also, health center and hospital and hospital। वो आप कहीं पे भी दे सकते हैं। उसको जनरली कहीं केयर लेता है तो उसके लिए थोड़ा आसान होता है। उसमें केवल और केवल फिजिकल पेन के ऊपर या फिजिकल नीड्स के ऊपर हम लोग ध्यान नहीं रखते हैं, पर क्योंकि उसमें साइकोलॉजिकल, स्पिरिचुअल, सोशल सारी चीजों के ऊपर हम लोग देखते हैं और उस तरीके से उसका असेसमेंट करके उसका नर्सिंग करना चाहते हैं। ये सब चीजें करने के कारण क्या होता है कि व्यक्ति की क्वालिटी ऑफ लाइफ है उसको इम्प्रूव होता है एंड इट कैन बी डन मेनी टाइप्स ऑफ द हेल्थ प्रोफेशनल्स। ये एक मल्टीडिसिप्लिनरी टीम अप्रोच है। ऐसा नहीं कि इस टीम में मात्र डॉक्टर होता है, डॉक्टर, नर्स, काउंसलर, सोशल वर्कर्स और एनी लोकल एनजीओ दैट दे ऑल कैन पार्टिसिपेट इन दिस पैलिएटिव केयर। ओके, ये पैलिएटिव केयर का कब उसको जरूरत होती है तो जनरली क्या होता था कि पहले एंड ऑफ लाइफ केयर जो उसका कन्वर्सेशनल मॉडल था उसमें अगर आप देखोगे तो उसमें जब पेशेंट को एंड ऑफ लाइफ केयर के दौरान हम लोग बेसिकली शुरू करते थे, पर अब जब से डायग्नोसिस होता है पेशेंट का कोई भी क्रॉनिक कंडीशन का तब से हम शुरू करते हैं एंड इट विल बी एक्सटेंडेड पोस्ट डेथ आल्सो। ब्रेवमेंट सपोर्ट हम उसके फैमिली को भी देते हैं। तो इसमें हम पेशेंट उसके फैमिली इन दोनों को हम जो सपोर्ट देते हैं उसको पैलिएटिव केयर कहते हैं। बेसिकली ये पूरा मॉडल कौन कौन किस किस कंडीशन में उसकी जरूरत है। कार्डियोवैस्कुलर डिजीज से जो लोग ग्रसित है उनको जरूरत है, जिसको कैंसर डायग्नोज हुआ है, chronic lung disease, HIV, AIDS, diabetes, the people who need a palliative care don't receive ये है कि गैस क्या, सॉरी, तो इतनी कंडीशन की केयर भी जिसको चाहिए, क्योंकि इंडिया में अभी पैलिएटिव केयर कॉन्सेप्ट को इतना अच्छे से नहीं देखा गया है और इसके लिए एक्सेसिबिलिटी भी बहुत ज्यादा नहीं है। कोई स्पेशली पैलिएटिव केयर के वार्ड या हॉस्पिटल ऐसे अवेलेबल नहीं है। So 86% people who get the palliative care don't take it because lack of awareness, lack of accessibility or affordability also. Many of the times, अगर आप प्राइवेट हॉस्पिटल से जाते हैं तो you can't afford the n number of time of admission, तो इसलिए स्पेसिफिक कोई पैलिएटिव केयर का हॉस्पिटल या ऐसी गवर्नमेंट में भी अगर आपको एडमिशन डिजीज होता है तो एज पर द डिजीज कंडीशन आपको एडमिट किया जाता है। तो बट उसके लिए कोई स्पेशली पैलिएटिव केयर नहीं है, क्योंकि आपका केयर प्रोग्रेशन ऑफ डिजीज के हिसाब से स्पेशलाइज्ड केयर चाहिए। 83% ऑफ द वर्ल्ड पॉपुलेशन लैक एक्सेस टू द पेन रिलीफ। काफी बार क्रॉनिक टर्मिनल इलनेस के दौरान पेन बहुत ज्यादा होता है और 83% लोगों को काफी, अगर आप साउथ ईस्ट एशिया की अगर हम बात करते हैं, वेस्टर्न कंट्रीज में बात करेंगे तो पैलिएटिव केयर के स्पेशली पेन क्लिनिक्स। ओके, तो ये सारी चीजें भी अभी भी हमारे इंडिया में कहीं ना कहीं लैकिंग है और लोगों को इसके बारे में नॉलेज भी है। And 98% of children needing the palliative care live in low income. Children की अगर हम बात करें तो कुछ बच्चे जन्म से आनुवंशिक यानी कि हेरिडिटी डिसऑर्डर के साथ या जेनेटिक डिसऑर्डर के साथ बहुत होते हैं, जैसे कि सिकल सेल एनीमिया हो गया, थैलेसीमिया हो गया, हीमोफीलिया हो गया या कोई भी रेयर ब्लड डिसऑर्डर के कारण भी और उनको ये सारी पैलिएटिव केयर की आवश्यकता होती है। तो उस समय भी उनके पेरेंट्स को इतनी नॉलेज नहीं होती और हमारी हेल्थ सिस्टम भी इतनी रेडी नहीं है कि इतना जो बर्डन है उसको टैकल कर पाए या कैटर कर पाए। तो बैरियर्स के बारे में अगर हम बात करें तो एक तो अवेयरनेस है, बीइंग नर्सिंग इज द मोस्ट इंपोर्टेंट। यू हैव टू अवेयर द पर्सन हु इज सफरिंग विद chronic terminal illness। सेकंड थिंग, कल्चरल एंड सोशल बैरियर बहुत ज्यादा होते हैं, तो उसमें उनकी बिलीफ को रखते हुए हेल्थ बिलीफ मॉडल के आधार पर उनको ट्रीटमेंट देनी है। हेल्थ केयर वर्कर्स है दैट दे आर नॉट ट्रेन्ड फॉर द होम बेस्ड केयर नर्सिंग बिकॉज़ होम बेस्ड केयर इज अ लो रिसोर्स सेटिंग। Okay, or either you have to carry the maximum resource from the hospital or the hospital care and later later on you have to provide the care at the home environment. So many of the time the home based care के लिए अभी भी स्टाफ इतनी उनकी कैपेसिटीज नहीं है, तो इसलिए अलग अलग प्रकार के पैलिएटिव केयर कोर्सेज भी रन किए जा रहे हैं अलग अलग इंस्टीट्यूशंस के माध्यम से। उसमें भी हेल्थ केयर प्रोफेशनल्स को ध्यान से एनरोल करना चाहिए या पंजीकृत करना चाहिए और अपनी कैपेसिटीज बढ़ानी चाहिए। ओवरली रिस्ट्रिक्टिव रेगुलेशन फॉर द ओपियोइड पेन। अगर हम बात करते हैं पैलिएटिव केयर में, तो पैलिएटिव केयर की एक हमारी जो फार्माकोलॉजिकल ट्रीटमेंट है उसमें हमारा ओपियोइड भी हम लोग देते हैं। तो ओपियोइड ऐसा नहीं है कि वो हर एक जगह आसानी से मिल जाता है, क्योंकि उसके लिए लाइसेंसिंग देना पड़ता है। और ओपियोइड देने के लिए क्या इंडिकेशन है, कॉन्ट्राइंडिकेशन है, क्या केयर रखनी चाहिए, ये सारी चीजों के बारे में भी अभी तक लोगों को अवेयरनेस है। तो ओपियोइड डीलिंग कैसे करना है फॉर द पेन रिलीफ, ये भी अभी हमारे कैपेसिटी बिल्डिंग का एक विषय हो सकता है कि जिसमें हमें नर्सिंग फैकल्टीज को या नर्सिंग स्टूडेंट्स को बात करनी चाहिए। दूसरा इसके अलावा ये है कि उनको क्लिनिकल एक्सपोजर नहीं मिलता, because many of the times if I can correlate with my clinical experience, I had never been experienced like any patient is on the opioid and I had never managed such kind of cases. Okay, so many of the times lack of the clinical exposure, and we are also not talking in our fundamental lab or our clinical skill labs also. Okay, so we have to develop such kind of skill stations also to build the capacities of the nursing students and nursing professionals to have equip the knowledge with the dealing of the opioid care of the patient with the on the opioid analgesic. तो अब हमें क्या करना चाहिए? तो जैसे हमने ऑलमोस्ट बता दिया है कि वर्ल्ड हेल्थ असेंबली ने इसलिए इंटीग्रेटेड पैलिएटिव केयर मॉडल को नेशनल हेल्थ पॉलिसीज में इंटीग्रेट किया। इसके अलावा कुछ लॉज को रिवाइज किया है ओपियोइड पेन रिलीफ के लिए। सभी का भारत सरकार के माध्यम से पैलिएटिव केयर का हर एक कैडर का एक मॉड्यूल बनाया गया है। नर्सिंग ऑफिसर्स का हो, चाहे एएनएम का हो या मल्टीपर्पज वर्कर का हो, आशा का हो और मेडिकल ऑफिसर का हो, सभी कैडर का एक पैलिएटिव केयर का मॉड्यूल बनाया गया है। इवन इंडियन नर्सिंग काउंसिल हैज आल्सो रिवाइज्ड curriculum, and in that curriculum also this component was integrated. इस कंपोनेंट को इस करिकुलम में भी लिया गया है एज अ मैंडेटरी मॉड्यूल। ओके, तो ये सब चीजें दर्शाता है कि इट्स अ हाई टाइम दैट वी नीड टू इन्वेस्ट इन द पैलिएटिव केयर, बिकॉज़ दर बदर केसेस बहुत ही बढ़ रहे हैं इसलिए, और पीपल एक्चुअली रिक्वायर द पैलिएटिव केयर बट people don't know whether that type of services and program is available, and the healthcare providers are also trained in that. तो ये बेसिकली हमारा पैलिएटिव केयर का एक बैकग्राउंड था। आई होप कि सभी को पैलिएटिव केयर के बारे में थोड़ा आइडिया आया होगा, क्योंकि हमारा सारा प्रेजेंटेशन एक स्लाइड से दूसरे स्लाइड से कोरिलेटेड है। तो अगर आपने पैलिएटिव केयर अच्छे से समझ लिया है तो आपको पेन एंड पेन मैनेजमेंट समझने में थोड़ी आसान है। ठीक है, ये कुछ बेसिक डेफिनेशन है पैलिएटिव केयर की जो WHO के माध्यम से दी गई है कि पैलिएटिव केयर व्यक्ति को मात्र फिजिकली चीजों को इंप्रूव करने में हेल्प नहीं करता है, पर वो व्यक्ति की रोजमर्रा की लाइफ को भी इम्पैक्ट करता है। वो अपनी पैलिएटिव केयर देखिए हमारे लिए एक स्वस्थ व्यक्ति के लिए अपनी रोजिंदा एक्टिविटियों के लिए करना बहुत ही आसान होता है, पर जब व्यक्ति कोई क्रॉनिक टर्मिनल इलनेस से सफर होता है तो उसके लिए वही छोटी छोटी एक्टिविटी करने में भी उसको बहुत दिक्कतों का सामना करना पड़ता है। तो इसलिए पैलिएटिव केयर क्या करती है कि जो व्यक्ति की स्पेसिफिक नीड है उसको हम कैसे इंप्रूव कर सकते हैं, उस पर ध्यान देंगे कि जिससे व्यक्ति अपना ख्याल खुद रख पाए। ठीक है, पेन मैनेजमेंट, उसमें उसको पेन को हम दूर कर पाए जिससे वो व्यक्ति अपना आराम से अपना रोजिंदा कार्य कर सके, और जिससे क्या होगा कि उसकी क्वालिटी ऑफ लाइफ को इंप्रूव कर पाएगा। ठीक है, तो इनको मेडिसिन में आप सपोर्ट कर सकते हैं, फिजिकल केयर, इमोशनल सपोर्ट, स्पिरिचुअल सपोर्ट। तो पैलिएटिव केयर क्या करता है कि व्यक्ति की ओवरऑल क्वालिटी लाइफ को इंप्रूव करने में मदद करता है by integrating the physical care, medicine, spiritual and emotional support। and इससे क्या होगा कि व्यक्ति का प्रोग्रेशन ऑफ डिजीज तो होगा, हम प्रोग्रेशन ऑफ डिजीज या उसकी डेथ को किसी भी तरीके से कंट्रोल नहीं कर पाएंगे, पर उसको क्वालिटी टाइम में हेल्प कर पाएंगे। जितना समय भी व्यक्ति हमारे बीच में है उसको हम एक अच्छा जीवन दे पाएंगे, उसके सिम्टम्स को हम कम कर पाएंगे। दैट इज ऑल द ऑब्जेक्टिव, रिस्टोरेशन ऑफ द लाइफ, दैट विल बी वन ऑफ द मोस्ट इंपोर्टेंट ऑब्जेक्टिव ऑफ द पैलिएटिव। ये कुछ पैलिएटिव केयर के बारे में अक्सर लोगों को पता नहीं होता, तो ये कुछ मिथ्स रहती है, तो मैं एक दो मिथ्स आपको बताता हूँ। बाकी आपके पास स्लाइड्स है तो आप उसको रीड कर सकते हैं, या इंडियन एसोसिएशन ऑफ द पैलिएटिव केयर है उसके ऊपर जाकर भी आप बहुत सारे कोर्सेज भी कर सकते हैं। और ये सारे इंफोग्राफिक्स वहां पे अवेलेबल है, आप उसको डाउनलोड करिए और अपने पास रखिए और अपनी चीजों को आप अपनी नॉलेज को भी बढ़ा सकते हैं। तो पैलिएटिव केयर इज ओनली फॉर कैंसर, तो वो एक मिथ है। पैलिएटिव केयर मात्र एक कैंसर नहीं है, ठीक है। पर पैलिएटिव केयर सभी क्रॉनिक टर्मिनल इलनेस पेशेंट्स के लिए, जो हमने पहले स्लाइड में देखा, पैलिएटिव केयर इज एंड ऑफ लाइफ केयर ओनली फॉर द डाइंग पेशेंट। नो, पैलिएटिव केयर इज स्टार्ट फ्रॉम द इनिशिएशन ऑफ द डायग्नोसिस, या जब से हम डायग्नोसिस करते हैं तब से होता है। और मात्र उसमें एंड ऑफ लाइफ केयर नहीं होती, पर उसमें ग्रेवमेंट सपोर्ट भी होता है। ग्रेवमेंट सपोर्ट का मतलब ये होता है कि फैमिली मेंबर्स को भी, वो ग्रीफ के स्टेज में है या उस समय के दौरान जब व्यक्ति की मृत्यु हो जाती है, तो उसको 6 महीने तक थोड़ा सपोर्ट करते हैं, उसको ग्रेवमेंट सपोर्ट कहते हैं, ठीक है। पैलिएटिव केयर मींस गिविंग अप ऑन क्योर और ट्रीटमेंट, ओके। तो इसका मतलब ये नहीं होता है, ये है कि पैलिएटिव केयर कॉम्प्लीमेंट्स द ट्रीटमेंट, उससे आपका डिजीज वैसा नहीं हो जाएगा कि आपने पैलिएटिव केयर शुरू किया तो डिजीज क्योर हो जाएगा, ठीक है। पर डिजीज को के साथ आप अपनी क्वालिटी ऑफ लाइफ या रिस्टोरेशन ऑफ लाइफ कैसे कर पाते हैं, उसके ऊपर इंपॉर्टेंट है। पैलिएटिव केयर ओनली मैनेज पेन इन अदर डिस्ट्रेसिंग तो फिजिकल थिंग्स। पैलिएटिव केयर आपकी फिजिकल, इमोशनल, स्पिरिचुअल एंड सोशल सभी नीड्स को होलिस्टिक वेलबीइंग के लिए होता है। I request from the audience if anyone can read a fixed number of the main and fact. कोई अगर पढ़ सकता है? Any participant is interested to read? Just write it in the chat so the host can do the needful. Okay, I think participants have some limitations. I think they are unable to. Okay, and some of the thank you, President, for highlighting this. Not readable font, so I will thank you. And you can also download these images from the Indian Association of the Palliative Care viewpoint. So it's, I think it's not readable, so I'm not reading all the myths and facts. I just ask the organization to share this PPT with everyone, so everyone can go through this slide. So basically, this slide, the purpose of this slide is कि palliative care is having so many myths, and as a nursing personnel or a nursing professionals, it's our own responsibility to replace the myths with the facts. So the community awareness is very important. So if the community is rightly aware on this topic, so they are able to access the palliative care services and those who need. Okay. So जिनको भी जरूरत है वो palliative care की सर्विसेज को ले सकते हैं। अब हम क्वालिटी ऑफ लाइफ के ऊपर बात करेंगे। तो ये WHO का एक पेपर था, उसमें दिया गया है कि क्वालिटी ऑफ लाइफ कौन कौन से पैरामीटर्स अगर हम देखते हैं किसी व्यक्ति को, अगर हमें क्वालिटी ऑफ लाइफ अच्छी है ऐसा कहना है, कौन कौन से डोमेन पे हमें देखना पड़ेगा, ठीक है। तो व्यक्ति का हम फिजिकल चीजें, एज ए नर्सिंग पर्सनल हमारा ज्यादा फोकस उसकी फिजिकल नीड्स के ऊपर होता है, बट वी ऑल्सो नीड टू टेक केयर ऑफ हिज और हर साइकोलॉजिकल और स्पिरिचुअल नीड। साइकोलॉजिकल और स्पिरिचुअल नीड को हम कैसे कैटर कर सकते हैं या कैसे उसको हम पढ़ाई कर सकते हैं, साइकोलॉजिकल या स्पिरिचुअल सेवाएं। तो साइकोलॉजिकल और स्पिरिचुअल सेवाएं करने के लिए पैलिएटिव केयर में एज अ मल्टी टीम या मल्टीटास्किंग मॉडल है हमारा। तो उसमें हम काउंसलर को इन्वॉल्व कर सकते हैं, उसकी पर्सन की रिलीजियस फीलिंग्स क्या है उसका इंटरव्यू कर सकते हैं, उसको अलाउ कर सकते हैं, जितनी रिलीजियस फीलिंग्स को हम अलाउ कर सकते हैं वो। फैमिली इज वन ऑफ द इम्पोर्टेंट कंपोनेंट ऑफ द पैलिएटिव केयर मॉडल, तो उनकी भी सोशल, साइकोलॉजिकल एंड स्पिरिचुअल, ठीक है। तो अगर आप देखोगे कि क्वालिटी ऑफ लाइफ में हम 3 कंपोनेंट को देखते हैं, पेशेंट को तो देखते हैं पर उसकी फैमिलीज को भी देखते हैं, क्योंकि मेनी ऑफ द टाइम फैमिलीज इज आल्सो हैविंग द बर्नआउट सिंड्रोम। और अगर आप उस चीज को समय पे टैकल नहीं करोगे तो उसके कारण उनको भी काफी सारे मेंटल हेल्थ इश्यूज, पोस्ट ट्रॉमेटिक स्ट्रेस डिसऑर्डर और बहुत सारे मेंटल इश्यूज भी देखने को मिलते हैं, चाहे वो डिप्रेशन हो या पोस्ट ट्रॉमेटिक स्ट्रेस डिसऑर्डर। प्रोवाइडर्स की अगर हम बात करें तो साइकोलॉजिकल एंड स्पिरिचुअल दोनों चीजें देखने को मिलती है। प्रोवाइडर्स क्योंकि काफी पैलिएटिव केयर इज अ लॉन्ग टर्म प्रोसीजर, so many of the time the professionals or the caregivers who are involved in the care of the patient, maybe they have a psychological attachment and they have a great try to save the patient, but sometimes patient will lose his or her life. So many of the time, for the psychological and spiritual consideration for the providers also we need to take in care. तो the hospitals में भी ये provision होना चाहिए कि अगर किसी हेल्थ केयर प्रोवाइडर के नर्सिंग प्रोफेशनल्स को मेंटली तौर पर कोई इश्यूज आ रहे हैं या स्ट्रेस हो रहा है तो उनकी भी काउंसलिंग की जाए. So the quality of life dimensions of care is concerned not only with all aspects of the patient's needs but also with the needs of the family and healthcare. तो जब हम क्वालिटी ऑफ लाइफ की बात करते हैं पैलिएटिव केयर में तो हमें इन तीनों कंपोनेंट्स पे ध्यान देना है. नॉट ओनली addressing the needs of the patient but also we have to consider families and providers needs as well. ओके, तो ये बहुत ही ध्यान रखें क्योंकि एज अ नर्सिंग प्रोफेशनल जब आप पैलिएटिव केयर के कभी आपको अपॉर्चुनिटी मिलती है कि हमें पैलिएटिव केयर के पेशेंट्स को ट्रीट करना है तब आप तीनों लोगों को केयर प्रोवाइड करें ऑन ऑल दिस थ्री डोमेन फिजिकल साइकोलॉजिकल एंड स्पिरिचुअल. उसमें आपका फिजिकल कंपोनेंट ओनली एलिजिबल फॉर द पेशेंट बट रेस्ट ऑफ द टू कंपोनेंट्स लाइक फैमिलीज एंड प्रोवाइडर्स है वहां पे आपका साइकोलॉजिकल एंड स्पिरिचुअल इज द कॉमन वन एंड फैमिलीज मेनी ऑफ द टाइम द सोशल प्रेशर इज आल्सो देयर. So that's why we have to consider the social segment. This is the quality of life definition. So just I want to brief you like to whom we can consider as a quality of life. Okay, an individual's perception of their position in life to context the culture and value system means quality of life में अगर व्यक्ति का आप culture and value नहीं समझते हो और उसको allow नहीं करते हो so that will overall impact on their spiritual part as well as their psychological part in which they live in their relation to their goals, expectations, standards and concerns. ओके, जिससे इनका स्टैंडर्ड एक्सपेक्टेशंस और कंसर्न्स होती है. एंड क्वालिटी ऑफ लाइफ इज अ डिग्री टू व्हिच इंडिविजुअल इज हेल्दी, कंफर्टेबल, एबल टू पार्टिसिपेट एंड एंजॉय देयर लाइफ. अगर आप उनकी सोशल फीलिंग्स को या उनके कल्चर को अलाउ करते हैं तो व्यक्ति एक हेल्दी एटमॉस्फेयर में जी सकता है. तो ओवरऑल उनके सारे कंपोनेंट्स आपके फिजिकल, सोशल, स्पिरिचुअल सारे कंपोनेंट्स को अच्छी तरीके से वो एंजॉय करता है. ठीक है, और वो क्या करता है कि कंसल्ट वेदर द डिजीज इम्पेयरमेंट लिमिट्स अ पर्सन एबिलिटी टू फुलफिल अ नॉर्मल रूटीन. ठीक है, अगर व्यक्ति अपने नॉर्मल रूटीन कंप्लीट कर पा रहा है और वो सेटिस्फाइड है अपनी चीजों से तो उसको क्वालिटी ऑफ लाइफ कहते हैं. क्वालिटी ऑफ लाइफ की डेफिनेशन व्यक्ति से व्यक्ति वन साइज डजंट फिट फॉर ऑल. ओके, मतलब मेरे लिए जो क्वालिटी ऑफ लाइफ है वो शायद आपके लिए ना. ठीक है, तो जब हम बात करते हैं कोई व्यक्ति की जो क्रॉनिक टर्मिनल इलनेस से सफर हो रहा है तो उसके लिए अपनी एक्टिविटी ऑफ डेली लिविंग करना है, ये भी एक बहुत बड़ी बात है क्वालिटी ऑफ लाइफ में. अपनी बात दूसरे को कह पाना, अपनी बात दूसरा सुन ले, उसको समझ ले, दैट ऑल थिंग्स कंसीडर्ड एज अ क्वालिटी. ओके, तो क्वालिटी ऑफ लाइफ सब्जेक्टिव होती है, आपके लिए अलग हो सकती है, मेरे लिए अलग हो सकती है. ठीक है, और वो पर्सन के डिस्क्रिप्शन के ऊपर होती है. ठीक है, और क्वालिटी ऑफ लाइफ इज चेंज टाइम टू टाइम. ओके, आज उनके पास पेन और है, पेन और फिजिकल प्रॉब्लम्स है तो उसकी भी क्वालिटी ऑफ लाइफ यही कि उसका पेन रिलीफ हो जाए और वो कुछ अच्छे पल बैठ पाए, उसका पेन रिलीफ हो पाए, वो अपने परिवार वालों से बात कर पाए. दैट इज अ क्वालिटी. बट टुमारो maybe the same thing is not there for the quality of life because tomorrow might be the patient is cured with the illness. तो उस समय उसका रिहेबिलिटेशन उसके लिए क्वालिटी ऑफ लाइफ. ठीक है, तो क्वालिटी ऑफ लाइफ एक तो पर्सन टू पर्सन अलग हो सकता है एंड इट इज डिफरेंट फ्रॉम टुडे टू टू. ये बहुत जरूरी है. और क्वालिटी ऑफ लाइफ के लिए WHO के माध्यम से 2 या 3 टूल है जिसमें 26 पॉइंट्स है एक में और एक में 100 पॉइंट्स है. तो अगर आप WHO क्वालिटी ऑफ लाइफ टूल डालेंगे तो आपको मिल जाएंगे. अलग अलग लैंग्वेजेस में वो क्वालिटी ऑफ लाइफ टूल भी अवेलेबल है. ठीक है, कि अगर आप जैसे कोई पेशेंट कैंसर से ग्रसित है या HIV से ग्रसित है, अगर आप उसको क्वालिटी ऑफ लाइफ का टूल आप उपयोग करते हैं और फिर उसकी स्कोरिंग करते हैं जिससे आपको पता चलेगा कि व्यक्ति कौन से डोमेन में ज्यादा ग्रसित है, वेदर इट्स साइकोलॉजिकल, स्पिरिचुअल और फिजिकल. ओके, तो जिससे जब भी व्यक्ति पैलिएटिव केयर पे हो तो इट्स बेसिकली वर्क ऑफ द साइकोलॉजिस्ट और अ नर्सिंग प्रोफेशनल. ये साइकोलॉजिस्ट इज नॉट. तो आपको ये सारा टूल्स भी पता होने चाहिए. क्वालिटी ऑफ लाइफ के टूल्स क्या है. आई हैव नॉट कवर्ड दैट टूल बट इफ समवन रिक्वायर्स दैट टूल आई विल शेयर द लिंक इन द चैट. ओके, थैंक यू. अब तक हमने जो बात की वो हमने पैलिएटिव केयर और क्वालिटी ऑफ लाइफ के बारे में बात की. अब जो हम नेक्स्ट स्लाइड में बात कर रहे हैं वो है पेन. सभी को पता है एंड एवरीवन इज सफर्ड विद द पेन. Might be the severity is different. Okay, somebody is having the abdominal pain or somebody is having the accident, so post-operative pain. Okay, somebody is having the labor pain. So all individuals are suffering with the pain in the various life cycles. Pain is nothing but an unpleasant stimulation or an emotional experience associated with the actual or a potential tissue. पेन कैन आप अगर मेडिकल सर्जिकल में आपने पेन का स्पेसिफिक टॉपिक पढ़ा होगा तो यू हैव अ different types of the pain also. Acute pain is there, chronic pain is there, malignant pain is there, neuropathic pain is there, non-receptor pain is there, breakthrough pain is there. So there are n number of types of the pain also. ओके अगर हम यहाँ पे जो बात कर रहे हैं पेन तो हम स्पेसिफिक यहाँ पे बात करें क्रॉनिक पेन की. क्रॉनिक पेन का मतलब ये होता है कि द पेन हु इज एसोसिएटेड विद द 6 months or more than with the person. उसमें व्यक्ति उसकी इंटेंसिटी बता सकता है, सिवियरिटी बता सकता है, बट कहाँ पे पेन हो रहा है नहीं हो रहा है उसके पास, क्योंकि पेन उसके जीवन का एक हिस्सा बन जाता है. ठीक है, तो ओवर द टाइम इट बिकम्स मोर डिफिकल्ट फॉर द पेशेंट टू डिफरेंशिएट द एग्जैक्ट लोकेशन ऑफ द पेन एंड आइडेंटिफाई द इंटेंसिटी ऑफ. ओके, तो ये सब चीजें बहुत ही मैटर करती है. अगर कोई व्यक्ति आपको बताता है कि उसको बहुत समय से पेन है, मोर देन 6 months पेन है, इट विल बी कंसीडर्ड एज अ क्रॉनिक पेन. अगर कैंसरियस के इक्वेशन तो क्रॉनिक मैलिग्नेंट पेन या नॉन मैलिग्नेंट पेन हो सकता है, बिनाइन ट्यूमर है तो क्रॉनिक पेन डिफरेंट होता है एक्यूट पेन से. एक्यूट पेन क्या होता है, इट्स अ टाइम बीइंग होता है और जब आपको इंटरवेंशन करते हैं तो पेन विल बी सबसाइड. बट क्रॉनिक पेन में इंटरवेंशन आपके जब आप करोगे तो आपको बहुत ही कम टाइम के लिए वो आपको रिलीफ देगा एंड द लेटर ऑन द अगेन पेन विल बी. तो ये आप सभी को पता है कि पेन कैसे होता है और पेन में हमें क्या क्या करना है. बीइंग अ नर्स सबसे पहला हमारा काम है टू असेस द पेन, व्हिच टाइप ऑफ पेन इज देयर. तो पेन असेसमेंट के लिए बहुत सारे स्किल्स हैं, तो वो मैं आपको नेक्स्ट स्लाइड में भी बताऊंगा कि आप कौन-कौन से स्किल्स यूज कर सकते हैं. व्हिच इज वेरी देयर आर 2 स्किल्स, मल्टी डायमेंशनल एंड यूनिडायमेंशनल, वो हम आगे बात करेंगे. ठीक है, so I think this part of the till this part if there is any I am having a 1 minute break over here or pause. ओके, अगर आपका कोई भी क्वेश्चन अभी तक है तो आप प्लीज पूछ सकते हैं. आई एम हैप्पी टू आंसर. आई एम लुकिंग फॉरवर्ड. स्टॉप्ड. जस्ट 1 minute break or 1 minute pause. If there is any question, please let me know. Otherwise, we'll move forward. You can write in the chat box as well. आप चैट बॉक्स में लिख सकते हैं. हिंदी में भी लिखेंगे तो चलेगा, हिंदी इंग्लिश मिक्स लिखेंगे तो भी चलेगा. ओके, so I think there is no question. We will move forward. These are the principles of the pain management. Okay, principles of pain management में 8 principles हैं. Consider patient as a whole. Okay, patient as a whole मतलब not only consider the physical needs but also consider the spiritual, psychological and social. Evaluate symptoms thoroughly. जब भी ऐसे नर्सिंग असेसमेंट आप करते हैं तो उसके सारे सिम्टम्स आप देख लीजिए. ठीक है, तो उसका कंप्लीट नर्सिंग असेसमेंट कीजिए, तो यू विल हैव अ क्लियर पिक्चर एंड बेसलाइन डेटा एंड इनसाइट्स अबाउट द पेशेंट्स कंडीशन एंड इफेक्टिव कम्युनिकेशन इज वेरी इंपॉर्टेंट. जब भी आप पेशेंट के साथ असेसमेंट करते हैं तो ट्राई टू कम्युनिकेट, ट्राई टू एंगेज द पेशेंट इन हिज और हर ओन वे. ओके, तो इसलिए उनसे पूछिए कि वेदर हाउ ही फील्स. ओके, ट्राई टू एम्पैथाइज हिम. ओके, एम्पैथाइज का मतलब ये होता है कि आप जब पेशेंट से बात करते हैं तो पेशेंट को लगे कि आप खुद अपने आप को वो सिचुएशन में रख रहे हैं. ओके, और आप उसकी सिचुएशन अच्छे से समझ सकते हैं. तो आपका कम्युनिकेशन इफेक्टिवली होना चाहिए. ओके, आपको कोई भी फॉल्स वादा नहीं करना है कि आप तो ठीक हो जाए. आपको फॉल्स प्रॉमिसेस नहीं करने हैं. ठीक है, आपको जो भी उसकी बातें हैं उसको फैक्ट के थ्रू करनी है. ठीक है, so communication is very important when the person is suffering with the palliative care, because person is having the daily new symptoms and person is having the daily new updates with his or her own life. Okay, and patient might be confused, patient is having a fear of dying. So patient most of the time patient is irritating, angry. So we have to communicate and tackle very nicely with the patient. We have to counsel the patient, and that is the nursing personnel is the cornerstone or a backbone for the counseling, because they are the first point of contact of the patient. करेक्ट करेक्ट, जितनी चीजें आप सही कर सकते हैं उतनी आप करें. ठीक है, बेसिकली आपका कंट्रोल होगा उनके फिजिकल सिम्टम्स के ऊपर. तो उन चीजों को आप थ्रू द मेडिसिन, थ्रू द छोटे छोटे इंटरवेंशन, आप कुछ कंफर्ट डिवाइस प्रोवाइड कर सकते हैं उनको, आप कुछ एनवायरमेंट मॉडिफिकेशन कर सकते हैं। तो दीज ऑल थिंग्स दैट यू कैन डू दैट प्लीज। जैसे उनका करेंगे करेक्टिव में अगर हम एग्जांपल दें, तो अगर उनकी कोई स्पिरिचुअल बात है जो आप कर सकते हैं, उनको मान लो कुछ रीडिंग करवाना है, ठीक है, उनको सुनना है, तो दैट थिंग्स कैन बी कंसिडर्ड। ओके, तो जो आप चीजें कर सकते हैं उसको आप करेंगे। कीप ड्यूरिंग कीप ड्रग ट्रीटमेंट सिंपल, ठीक है। जब आपको एंड ऑफ लाइफ केयर आप अगर चैप्टर पढ़ेंगे तो उसमें हम देखते हैं कि बहुत ही, क्योंकि एक छोटी सी रेस्क्यू भी पेशेंट को बहुत ज्यादा यूज, ठीक है, उस समय हम आईवी इन्फ्यूजन न देते हुए हम लोग उसको सबक्यूटेनियस इन्फ्यूजन, ठीक है। सो द ट्रीटमेंट इज वेरी सिंपल, नेजल स्प्रे दे सकते हो आप, ठीक है। ऑक्सीजन भी मैनी ऑफ द टाइम्स अगर पेशेंट्स एंड ऑफ लाइफ केयर में है तो हम ऑक्सीजन निकाल देते हैं। सॉरी, इज देयर एनीथिंग टू शेयर? कैन आई कंटिन्यू? ओके, so try to keep drug treatment is very simple. Okay, if you are confirmed like patient is dying, then omit all type of opioid analgesics or non opioid analgesics also. Okay, just have a simple elements that you can do, which is a core nursing intervention. Review and adjust treatment regularly. जब आप देखते हैं कि पेशेंट लॉन्ग टर्म पे है तो उसकी ट्रीटमेंट को रेगुलरली रिव्यू करिए बेस्ड ऑन देयर सिम्टम्स, और अगर उनके सिम्टम्स रिलीव हो रहे हैं तो उसका ड्रग आप टेपर्ड ऑफ कर सकते हैं, ठीक है। साथ में अगर सिम्टम्स वर्जन हो रहे हैं तो आप एडिशनल मोडालिटीज ऑफ ट्रीटमेंट भी कर सकते हैं। यूज नॉन फार्माकोलॉजिकल ट्रीटमेंट। Here is the point where our nursing professionals can do a wonder on that. Okay, so the non-pharmacological approach is in our hand. I have a separate slide for them. Like I already highlight what are the comfort devices we can use, environmental modifications technique, some type of active and passive physiotherapy, mind body relaxation, music therapy. This all spiritual therapy. This all comes under a non-pharmacological. Plan in advance and keep stuff. Whatever activities you are planning, that must be in advance based on their assessment of the symptoms, and keep all the concerned staff informed. ऐसा नहीं कि मैंने कल सोचा कि मैं इनको पैसे एक्सचेंज कराऊंगा, but today you are not able to, today you are not informed, today you are not informed to the physiotherapist, or today you are not informed the psychologist for a planned counseling session. So any activity that you are planning in consultation with the doctor as a multidisciplinary team members, we have to involve each category of the staff, so we can plan the care, we can plan care in advance and all the staffs are informed. Okay, so these all are the principles of the pain management. When you are managing the pain as a nursing professional or nursing leader, at this time you have to keep this point in your mind. Okay, now your most important part to assess them. So there is an acronym which is known as the PQI. Okay, and every acronym is having their own name. So PQRST is P means provoke. What promotes the pain? What palliating and precipitating. So cause क्या है उस पेन का, ठीक है। जब वो पोजीशन चेंज करते हैं तब उनको पेन होता है, या फिर जब आप उनको ड्रेसिंग करते हैं तब उनका पेन हो रहा है। तो एज अ नर्सिंग पर्सनल वी हैव टू आइडेंटिफाई द प्रेसिपिटेटिंग। ओके, व्हाट मेक्स इट वर्स, उस पेन को कब वो ज्यादा बढ़ जाता है, ठीक है। व्हाट मेक्स इट बैड, अगर आपने पोजीशन उनकी चेंज की है, ठीक है, आपने लेफ्ट लेटरल पोजीशन की जगह उसको सुपाइन पोजीशन कर दी है या पावलर पोजीशन कर दी है, देन द पेशेंट इज मोर कंफर्टेबल। So you have to observe all these things in picture. What previous treatment have you tried to relieve your pain? अगर कुछ previous treatment थी कि जिसमें उनका pain relief हो गया था, might be it's a opioid analgesic or non-opioid analgesic or mild analgesic. What kind of analgesic we use in the previous treatment when the person suffered from the similar kind of thing? whether they effective, अगर आपने उनको कोई एनर्जेटिक या वो दिया है या नॉन फार्माकोलॉजिकल ट्रीटमेंट किए तो उसकी इफेक्टिवनेस क्या, ठीक है। दैट एवरीथिंग यू हैव टू डॉक्यूमेंट एज अ नर्सिंग रिपोर्ट और नर्सिंग record, so the other nurse can also refer your nursing notes while the patient is having the similar kind of episode. Now the quality, what type of pain the patient is. So it's about a subjective part. Okay, that we can ask when you are having the nursing diagnosis. The assessment is having the two components, subjective assessment and the objective assessment. Objective assessment is generally done by the healthcare providers, and subjective assessment is the patient's word, the patient's feeling, the patient's facial expression. So the quality, what does your pain feel like? Okay, तो ये आप पेशेंट से पूछ सकते हो कि आपका पेन कैसा है. अगर पेशेंट बताने की कंडीशन में है तो what words would you use to describe your pain? Is it sharp, dull, stabbing, burning, crushing? You can give a hints to the patient, so the patient can choose the most appropriate answer. Like radiating pain is there or not? Okay, where does the pain radiate? जब आपका पेन शुरू होता है तो कहाँ से कहाँ रेडिएट होता है? Is it at the one place? Does it go anywhere else? या कोई दूसरी जगह पे जाता है? ठीक है, go anywhere else? Did it start elsewhere or now localized to one spot? वो एक जगह पे शुरू होकर एक जगह पे रहता है कि एक जगह से दूसरी जगह रेडिएट? So these all things you have to consider while assessing a patient with the pain. Severity क्या है? Severity के लिए basically we are using a pain scale. Okay, there are two types of pain scale: univariate scale and the multivariate scale that we will discuss in the next. So the whatever the scale as per the conditions or where you are applying, you have to score. Or if the patient is having the severe pain, then you have to discuss with this your doctor, and as per the doctor's prescriptions, you have to plan the medication. Simultaneously, you can also plan the non-pharmacological treatment. Time of the pain, like when pain starts, when it ends, what is the intensity, how long does it last, and how often does it happen? दिन में 2 बार हुआ, दिन में 3 बार हुआ, दिन में 4 बार हुआ, कितनी बार? ठीक है. और अगर पेन था तो उसका ड्यूरेशन क्या रहा? इट लास्ट फॉर द 30 मिनट्स, 10 मिनट्स, 20 मिनट्स. तो ये सब लिखने से क्या होगा कि आपकी नर्सिंग केयर की इफेक्टिवनेस भी आपकी बढ़ेगी. ठीक है, जैसे कि कल पेशेंट को पेन हुआ था, फिर आपने नॉन फार्माकोलॉजिकल अप्रोच किया एंड इट वुड बी रिड्यूस. ओके, सो दैट ऑल इज अ मेजरेबल इंटरवेंशन. आप जो भी कर रहे हैं उसका मेजर भी करना बहुत जरूरी है. जैसे हम लोग स्मार्ट ऑब्जेक्टिव लिखते हैं ऐसे ही. ठीक है, जब आप कुछ भी चीज प्लान करते हैं एज नर्सिंग केयर आप प्लान करते हैं तो सारी चीजें आप मेजर करेंगे. तो मेजर विल ऑलवेज एसोसिएटेड विद द प्रोग्रेस और फेल. ओके, failure doesn't mean you are failed in at your end, but failure in terms of the disease condition or disease progression. It's a high time that we need to think about the alternative strategy. So being a nurse, we have to accept the failure also. Like every time, what we are thinking and what we are planning that will not work in each kind of patient. So nursing persons are very smart and very effectively taken this as a अपॉर्चुनिटी ऑफ विंडो. इस चीज को हम एज अ अपॉर्चुनिटी ऑफ विंडो ले सकते हैं कि ये हमें अपॉर्चुनिटी है कि व्हाट वी कैन डू अ मच मोर बेटर फॉर दिस पेशेंट. एंड दिस टाइप ऑफ लर्निंग आल्सो you can have a better experience for the next time. Okay, good understanding of the patient's pain, patient pain forms the keystone of the development of the treatment plan. जब treatment plan बनाते हो तो आपको pain की कितनी understanding है, whether it's the severity, assessment, the quality of pain. If you understand this all stuff, then you can better plan for treatment of the patient. अगर आप TQRST के माध्यम से पेन की सारी चीजों के बारे में जानते हैं तो आप अच्छे से पेशेंट की ट्रीटमेंट प्लान कर सकते हैं. ठीक है, और पेशेंट का पेन अगर वेल कंट्रोल नहीं होता है एवरी एस्पेक्ट ऑफ द पेशेंट से, तो उसको सिंपल एक्टिविटी करने में भी, डेली लिविंग करने में भी उसको दिक्कत है. तो उस कंडीशन में हम उसको सपोर्ट चाहिए. उसमें हमें केयर गिवर्स को इन्वॉल्व करना चाहिए, फैमिली मेंबर्स को एजुकेट करना चाहिए, टीचिंग करना चाहिए और डेमोन्स्ट्रेट भी करना चाहिए. नॉन फार्माकोलॉजिकल अप्रोच आपको जिससे लगता है कि पेशेंट को फील कंफर्टेबल होता है, ये सारी चीजें हमें पेशेंट के होम एनवायरनमेंट के लिए हमें पेशेंट के रिलेटिव्स को भी सिखाना. This is the concept of the total. Okay, total pain is a concept given by the Saunders, and then is the Saunders. Basically, total pain is considered a psychosocial, physical, spiritual distress and combined the effect of the. Yes.
Good morning, sir. With due respect, we kindly request you to consider only 5 minutes for your address, as we are running short of time.
Sure, I will make it fast. Okay.
Okay, so thank you for your kind understanding, sir.
Right. This is a total pain slide, so I think it is now very understandable. Like we have to consider all domains of the care, like physical, psychosocial, spiritual, or okay. This is a case scenario, but due to the interest of the time, I am not covering. ये case scenario आपको दिया है, इसमें से आपको total pain के आंसर ढूंढने हैं और आपको उसमें से ये आइडेंटिफाई करना था कि कौन सा फिजिकल कंपोनेंट में जाएगा, साइकोलॉजिकल, सोशल एंड स्पिरिचुअल, दैट यू कैन कंप्लीट एट योर फ्री टाइम. ओके, and these are the answers, so you can check your progress by home. Okay, this is the slide that the pain scale measurement. So I am much more focusing on the measurement of the pain. So there are the two types of the pain, multidimensional and unidimensional. Multidimensional pain scales are not used because it's not easy to apply. हमारे क्लिनिकल सेटिंग में इसको हम अच्छे से अप्लाई करने में थोड़ा डिफिकल्ट है और इसमें टाइम टेकिंग भी है, इसलिए हम यूनिडायमेंशनल स्केल्स का उपयोग करते हैं, जैसे न्यूमेरिकल रेटिंग स्केल, वर्बल रेटिंग स्केल, विजुअल एनालॉग स्केल, वर्बल डिस्क्रिप्टर्स है और पेशेंट पेन रेटिंग स्केल व्हिच इज गिवन बाय द वॉन बेकर स्केल यूज्ड फॉर द किड्स. तो ये हमारे अलग अलग प्रकार के स्केल है. उसमें बहुत ही सिंपल दिया गया है कि अगर माइल्ड पेन है तो आप 1 2 3 का स्कोर आएगा, तो इस तरीके से आप उसको अप्लाई कर सकते हैं. और ये आपने मेडिकल सर्जिकल नर्सिंग में भी जब पेन का आपका प्रॉपर चैप्टर होगा तब आपने देखा होगा. तो इसलिए इस स्लाइड को मैं बहुत ज्यादा डिटेल में एक्सप्लेन नहीं करूंगा. ये बहुत जरूरी है, ये WHO का लेडर है पेन मैनेजमेंट का, ये आपके लिए नया है. ठीक है, जब भी पेशेंट को पेन होता है, ठीक है, तब हम 3 स्टेप में हम एनालिसिस एडमिनिस्टर करते हैं. तो माइल्ड पेन अगर है पेशेंट को, आपको ये 3 स्केल से पता चलेगा कि पेशेंट का पेन की कैटेगरी क्या है. माइल्ड पेन है तो हम नॉन ओपियोइड देते हैं, जिसमें आपका डाइक्लोफेनिक हो गया, ब्रूफेन हो गया. ठीक है, अगर मॉडरेट पेन है तो हम वीक ओपियोइड देते हैं, कोडीन एंड ट्रामाडोल देते हैं. तो यहाँ तक की सारी ड्रग्स आपके पास स्टेप 2 तक की ड्रग्स अवेलेबल होती है, बट स्टेप 3 वाली ड्रग है व्हिच इज अ स्ट्रॉन्ग ओपियोइड, जिसमें आपको मॉर्फिन, फेंटानिल एंड ब्यूप्रेनोफिन होता है. तो ये आपके लॉक इन की एक ये ड्रग्स होने चाहिए. ठीक है, मेडिसिन कवर्ड में डबल लॉक में होना चाहिए और ये डॉक्टर के स्पेसिफिक प्रिस्क्रिप्शंस में मिलता है. जनरली गवर्नमेंट हॉस्पिटल्स में, टर्शरी केयर लेवल हॉस्पिटल्स में ये उपलब्ध है. ठीक है, अब मैं फटाफट आपको मॉर्फिन के बारे में बता देता हूँ कि जो हम बात कर रहे हैं पेन मैनेजमेंट की, तो हमारा जो NSAID जो उसमें आप एसिटामिनोफेन, ब्रूफेन, डाइक्लोफेनिक, नेप्रेसोन, पिरासिमेन एंड केटोलेक भी आप यूज कर सकते हो. और वीक एंड स्ट्रॉन्ग ओपियोइड्स में कोडीन, ट्रामाडोल एंड मॉर्फिन यूज कर सकते हो. ये इसका स्टार्टिंग डोजेस है, तो ये आप आपके लेजर टाइम में पढ़ सकते हैं. ठीक है, मॉर्फिन को मैं बहुत ही फटाफट आपको समझा देता हूँ. मॉर्फिन की जो जनरल अवेलेबिलिटी है वो आपके टर्शियरी लेवल हॉस्पिटल्स में होती है. इसके कुछ हमने जॉबेड्स हैं जो यूज किए हैं, तो वो भी आप देख सकते हैं. ठीक है, मॉर्फिन का बेसिक यूज के बारे में अगर हम बात करें तो क्रॉनिक कैंसर के पेशेंट्स में होता है. जनरली ओरल मॉर्फिन हम लोग स्टार्ट करते हैं और पेशेंट को हम 2 या उससे ज्यादा डोजेस भी देते हैं जब उसको ज्यादा जरूरत होती है. तो जनरली 4 आवर्स भी हम लोग अप्लाई करते हैं. उसके साथ साथ आपको लैक्सेटिव्स देने होते हैं कि कॉन्स्टिपेशन का एक साइड इफेक्ट देखने को मिलता है. ठीक है, पेशेंट को हमें इनिशियल ड्राउजीनेस, पेशेंट को थोड़ा कॉन्शियसनेस का लॉस होगा और पेशेंट थोड़ा ड्राउजी रहेगा, तो उसके लिए हमें पेशेंट को या पेशेंट्स के रिलेटिव्स को हमें बताना होता है. आउट पेशेंट्स के लिए अगर हम बात करें तो डिटेल, टाइम, नेम, ड्रग, ये सारी चीजें हमें नर्सिंग रिकॉर्ड में रिकॉर्ड करनी होती है. ठीक है, ये बहुत जरूरी है कि आप जब मॉर्निंग स्टार्ट करते हैं तो उसको बाय द क्लॉक 4 आवर ही आपको करना है. और जैसे आप अगर रात में 10 बजे आप दे रहे हैं तो 10 बजे आप जो डोज देंगे उसमें आपको 2 डोज एक साथ देने हैं, जिससे पेशेंट की नींद खराब ना. ठीक है, तो डबल डोज हमें बेड टाइम पे देना है, जिससे आपका नेक्स्ट टाइम का 4 आवर्स का डोज भी हम उसी समय देते हैं. ठीक है, मॉर्फिन जो होता है उसमें कॉन्स्टिपेशन देखने को मिलता है, वॉमिटिंग देखने को, ड्राउजीनेस देखने को मिलता है, ये सब देखने को मिलता है. समय समय पे उसका रिव्यू करना होता है कि कब उसको ज्यादा करना है, कम करना है. ठीक है, तो और अगर उसकी मॉर्फिन की टॉक्सिसिटी बहुत ज्यादा हो जाए तो उसमें नैलोक्सोन का एंटीडोट है. तो यहाँ पे ये भी दिया गया है कि नैलोक्सोन आप कैसे यूज कर सकते हैं, ये वाली स्लाइड में है. तो उसमें बेसिकली रेस्पिरेटरी रेट देख के हम नैलोक्सोन देते हैं. तो मॉर्फिन की टॉक्सिसिटी को भी एज ए नर्सिंग पर्सनल आपको ऑब्जर्व करना है. ठीक है, ये नर्सिंग इंटरवेंशन है. तो नर्सिंग इंटरवेंशन को अगर हम ब्रीफ में बताना चाहेंगे तो आपको प्रॉपरली असेसमेंट ऑफ पेन करना है, विजुअल स्केल या एनालॉग स्केल्स आपको अप्लाई करने हैं. पेशेंट के सभी डोमेन्स को आपको ध्यान रखना है, फिजिकल, साइकोलॉजिकल, सोशल एंड स्पिरिचुअल, फार्माकोलॉजिकल एंड नॉन फार्माकोलॉजिकल दोनों अप्रोच है. ठीक है, ये नॉन फार्माकोलॉजिकल अप्रोच है. आपको कोल्ड एप्लीकेशन एंड हीट एप्लीकेशन, जिस एरिया में पेन हो रहा है वहां पे कोल्ड एंड हीट एप्लीकेशन कर सकते हैं, जिससे ब्लड सर्कुलेशन स्टिमुलेट हो सकता है और बेसिकली पेन रिलीफ हो सकता है. कंफर्टेबल असिस्टिव डिवाइस दे सकते हैं, पोजीशन चेंज कर सकते हैं, योगा, माइंड रिलैक्सेशन, डिस्ट्रैक्शन कर सकते हैं. जैसे पेशेंट बहुत पेन में है तो उसको कोई कॉमेडी शो लगा दिया या उसको कोई रिलीजियस आपने वो लगा दिया. एक्यूप्रेशर आप यूज कर सकते हैं, पर एक्यूप्रेशर के लिए पेशेंट की मोबिलिटी बहुत जरूरी है. प्रोग्रेसिव रिलैक्सेशन एंड इमर्जेंट म्यूजिक थेरेपी भी हम यूज कर सकते हैं, मसाज कर सकते हैं पेनफुल एरिया के लिए, एंड टेंस के लिए भी हम यूज कर सकते हैं, जो उसमें स्किन इलेक्ट्रोड्स का उपयोग करके हम लोग यूज करते हैं। इस बेसिकली इलेक्ट्रिकल नर्व स्टिमुलेशन है। तो ये सारी चीजें नॉन फार्माकोलॉजिकल अप्रोच करते हैं। सारी चीजों के लिए आपको ट्रायल एंड टेस्टेड मेथड यूज करना चाहिए, एंड एज पर द पेशेंट कंडीशन द मेथोडोलॉजी इज वेरी, एज पर द पेशेंट पेन सिवियरिटी आल्सो द मेथोडोलॉजी इज वेरी। So this is all about my presentation. अगर आपको कोई भी क्वेरी हो तो आप पूछ सकते हैं। I tried to cover it in very short time, but I hope it will be understandable. अगर कोई भी क्वेश्चन है तो आप पूछ सकते हो। And I really would like to thank you to the organizers for organizing this conference on 22 teams, and looking forward to further. Thank you. So I think the participant has no queries. So I request to hand over the organizers for the next section. Thank you.
Thank you so much, sir, for sharing such an enriching knowledge with us. Thank you so much, sir.
Welcome. Thank you.
So, dear participants, we are going to start session 2 of day 3 international conference. And for this session, Professor Dr. M. Jesleen ma'am, Principal of TMU College Muradabad, and ma'am will be giving us insight on overview call of EMBC. Ma'am, to this virtual session.
Yes. Yes, thank you. My slides is visible.
Yes, ma'am, it is visible.
Okay. ठीक है, I'll start. Actually, good morning to all those who are gathering in the international conference, 6th international conference organized by RK Institution of Counseling. First of all, I thanks for inviting us a guest speaker, that is Dr. Shiva Shankar. Thanks for that inviting me. But before entering into the topic, actually for my assigning topics, I have to take for the essential neonatal and pediatric care, equipment and protocol. What is essential? Participant, I am asking essential. Any idea? One minute. In day-to-day life, we are 1 minute screen sharing is 1 minute, ma'am.
Yes, sir. Yes, yes. Normal करके आप करिए, yes हो रहा है, yes ma'am. Yes, yes.
Okay, good morning again. Sorry for the interruption. So for my assigned topic is for the essential neonatal and pediatric care, equipment and overview. But in day-to-day life, wherever we are living, we need some of the essential things. So according to the essential things we are living, the same way for essential newborn care also, we have the essential meaning itself that is extremely important. So the same way we have to start with our session. Um, Then essential and neonatal pediatric care equipment protocol overview. So in our pediatric department or neonatal department, so that is a very important department. So this department we are thinking for the cornerstone of the any neonatal department. So we have to give a care for the neonatal or maybe pediatric emergency or pediatric area. We have to have a meticulous preparation. At the same time, we have to follow the prestigious protocol, and at the same time we have to have a dedicated and highly trained teams. So that is a main and important for the essential newborn care. So that why we have to have an unequally demand of the specialized equipment, and we have clear protocol, and we have many trained team. At the same time, we have updated protocol. For example, coupled or updated ventilation protocols. According to that only, we have to significantly enhance the safety and proper care we have to give. That is, we have to give for the holistic care, as plus we have to give for the comprehensive care to the patient according to the equipment as well as the protocol only. So at the same time, we have to have a commitment to give a care. For example, as the staff nurses or those who are working in the department, so they have to have an unwavering commitment to readiness, as well as to have a continuous improvement of the outcome of the vulnerable patient. Here, vulnerable patients mainly for the neonatal and children. So during any critical emergency, we have to have an unwavering commitments. If we have an unwavering commitment, only we are able to give an essential newborn care. Then the newborn care challenges in India. Already India faces significant challenges in newborn. So for example, there is a no proper document till now, even though some of the accounting for the 20% of the global birth or maybe 30% of the neonatal death still is there in India. Even though we are giving the concentration effort, the neonatal mortality rates remain high. Currently, as per the 2023 data, approximately 1,000 live birth, 20% of children are affected, neonatals are affected. But in this year, the target of National Health Mission target, as per current year, we are living in the 2025, is 2025, maybe 1,000 live birth may under that 16 per. This is a target of 2025. So how we have to reduce the 1,000 live birth may 16, how we have to give the main and important focus for as a nurse, we have to have a preventable death. How we are having the preventable death? Because the main important causes for the neonatal death for the infections or maybe birth asphyxia or maybe preterm birth. So these we have to focus properly. Automatically we have to reduce the neonatal mortality rate in this year. So that's why suppose we have to have a we have to have a drastic outcome. Drastic outcome we have to do, so then only timely care, appropriate care and appropriate intervention we are giving, only we are able to reduce the mortality rate. Mortality rate mainly we have to reduce for 16 per 1,000 live birth this year. Then the main objectives for the essential newborn care, already this is the point only we are going to discuss today. The main and important point is for the provide immediate and timely care for every newborn. and we have to prevent the hypothermia as well as all the infections, whatever infection the newborn is getting. Then establish the early breastfeeding and identify, manage at risk of high risk of newborn, and promote mother baby bonding. So this is the main objectives for the essential newborn care. So the main and important protocol for the at birth as well as the beyond the birth for maybe 1 to 2 years or up to 5 years, we have to follow the important protocol. So after delivery, because we have to follow the warmthness, because this is an important and key role factors of the all the newborns. With the immediate drying and warming the newborn automatically to prevent the hypothermia. So the hypothermia is one of the critical step for the neonatal survival. So that's why the warmth is very, very important. The first and important key for the protocol care at birth, we have to give a warmth to the newborn and warmth to the baby. Warmth to the baby means because previously in the olden days, after the delivery, the baby is cleaned with water, but nowadays only they are not using any water, only drying and warming the newborn to prevent the hypothermia. So this is a main important step for the survival. And second step, we have to go for the timely resuscitation. The resuscitation is very, very important. The resuscitation, we have to use an arm bag as well as the mask. So this resuscitation as well as the using this performed by the staff nurse, those who are trained with the Navajot Shishu Suraksha Karyakram, that's NSSK. So these people, they trained under the National Health Mission. To equip this National Health Mission, automatically equip all the healthcare workers who are working in the NICU. After that, they have to have a proper skill. This program will give a essential training to the patient, training to the staff nurses, those who are working in that area. After they have a skills, they have to do for the resuscitation to reduce the neonatal mortality rate. So this is also very important for the timely resuscitation. The next one is for the early breastfeeding. So every people know the initiation of breastfeeding within the first hour or within the half an hour, that is very important because that is mainly present in the colostrum. So this will provide the essential nutrition as well as the antibody to the patients. Next one is for the infection prevention. Already I told infection is a major important complications for the neonate as well as the asphyxia. After that, what we have to do, the implementation of the clean delivery practices. The implementation of the clean delivery practices means we know we have to follow the sterile technique while during the delivery of the whether the LFCS or maybe the normal delivery, and we have to go for the proper card care as well as the timely immunization. These three things is very, very important to protect the against the infection. Properly card care means we have to proper clamping is very important and proper cleaning is important. We have to use for the sterile technique, and timely immunization also very, very important to protect the against the infection prevention. The next one is for the yearly identification as well as the referral. Prompt identification. Prompt identification is nothing but if the patient is having birth asphyxia, if neonate is having any problem, prompt identification with efficient referral. Suddenly identification करने के बाद with the help of the pediatrician, we have to find identification of any problem, any issues. At the same time, we have to do the proper referral. Those who have high level of specialized intervention, but nearby, suppose the patient is delivering in any PHC, automatically the patient is suddenly shifted to government hospital, that's a district government hospital or any nearby good facility hospital. So this for the yearly identification at the same time referral. So this is a 5 protocol we are following means automatically to what we have to prevent the neonatal mortality rate also. The next one is for the infection control newborn. Infection control newborn care unit. That is infection control newborn unit is one of the major important neonatal health care. This every people know. But why I am telling means automatically neonatal area mainly the babies for the newborn, particularly preterm baby or maybe low birth weight infant. So this preterm baby or maybe low birth weight infant are all highly vulnerable to the infection due to their underdeveloped the immune system, because it's a baby newborn. Full immune system development is not at all properly occur. So that time they are because already they are a preterm baby or maybe low birth weight baby, so they have a less immune system, underdeveloped immune system. So that time we have to go for the essential newborn care guidelines. At the same time, infection control prevention measures. So automatically, if you are following the proper guidelines of ENBC or infection prevention control measures we are taking means we have to reduce the neonatal mortality as well as the morbidity, the reduce कर सकते. At the same time, in any area, for example, any PSC or any CSC or any maternity center, if the equipment is very less or any hospital, the resource is very limited, that time the infection rate related death is mainly high. So that's why any hospital in the newborn care or maybe any area, so they have to follow the proper infection control protocol, or they have a separate infection control neonatal care unit. So that is very important and crucial aspect of the neonatal health care. So we have to follow the proper guidelines of the infection prevention control measures or maybe essential newborn care guidelines. So next slide. So infection control unit may mainly we have to follow the hand hygiene. So already as a nursing student or as a nurse, we are following all the hand hygiene or hand washing technique. The same way, the hand hygiene is a cornerstone of the infection prevention. कोई भी infection prevention करने के लिए the main important thing for the hand hygiene. So that's why all the healthcare providers or maybe caregivers or maybe visitors, they have to follow the proper hand washing technique with the help of the using the soap or maybe clean water or maybe any alcohol based dandruff we have to use before and after handling the newborn, and each and every time, not only morning, not only afternoon, not only evening, whenever you are handling with any newborn or any cases, you have to follow the proper hand washing technique but before and after handling each newborn according to the essential newborn care guidelines. Regular reinforcement as well as the audit we have to conduct the hand hygiene practices, so that only if any complaints is coming, so we have any complaints is coming from that department or infection control department, we have to go for the audit for the once in a month and 15 days in a thing, and we have to go for the reinforcement and to ensure the compliance. So that is very important for the hand hygiene. And next one is for the safe cord and skin care. So as per the ENPC guidelines, clean cord care is very, very important. This is only recommended. Already I told productive, that is a cord care is very important. So why means why we are giving cord care means that is we have to prevent the omphallitis. So omphallitis is nothing but severe infection of the newborn. The newborn umbilical cord and umbilical stump, automatically the surrounding tissue become infected. Due to that one, the cord, the umbilical cord become a redness, swelling, as well as discharge or something. Through that only automatically the infection will entering into the umbilical cord to these patients. So that's why we have to have a proper guidelines to clean the cord, that is automatically to prevent the omphallitis as well as other infection also. So that's why always we have to keep the umbilical cord should be dry as well as be clean. Why means to avoid unnecessary complications. So that's why we have to use for the proper skin care and gentle cleaning. At the same time, minimize the exposure of the any weak minimize exposure of the any infected area, as well as mainly they have to follow the protective fragile skin barrier they have to do. The next one is we have to follow the clean and sterile environment. Maintaining clean and sterile environment in the newborn care unit is very, very mandatory, because all the unit care unit or maybe NICU or PICU koi bhi hai, we have to follow the proper clean and sterile environment to the newborn care unit. That is a mandatory. Mandatory is nothing but that is important only. So then we have to follow the surfaces, all the equipment, all the incubator should be regularly disinfected. At the same time, floor should be clean with appropriate disinfectant. At the same time, clutter should be minimized to allow the proper sanitation. So clutter in the sense, suppose any material present in the floor or any unnecessarily things available, so that everything we have to minimize and we have to keep for the proper sanitation. So that's why we have to prevent the clutter or to minimize the clutter. So that is clean and safe environment, very, very important. And next one is for the rational for use of antibiotic, because maximum what in the hospital setup we are doing or maybe doctors are doing, unnecessary using of antibiotics. So that's why overuse or misuse of antibiotic automatically leads to antimicrobial resistance. So that's why we have to identify the organism, which organism is mainly related to this infection. Otherwise, we have to identify the infections. Then after infections only, we have to treat with the help of the antibiotic. That is very important. At the same time, the essential newborn care advocates the how we are using the antibiotic based on the clinical science and laboratory confirmation. So that's why I told we have to identify the organism with the help of the blood investigation. At the same time, any clinical signs if the baby is having, and after that only we have to advise the baby, to administer the antibiotic to the neonates. That's why we have to ensure whether treatment is effective for the serious infections. That we have to confirm. So simple use of antibiotic or without consultation of the doctors, if you are using antibiotics, so that may be going for the antimicrobial resistance that will affect the baby, that is neonate. The next one is for the proper handling of equipment as well as devices. So for example, handling of equipment here mainly for the feeding tubes, catheters, any respiratory equipments or respiratory support. So these all should be sterilized as well as maintained properly. And sometimes any articles is available in the single use, and the same article we have to use for the single use purpose only and should not be reused. And the same time we have to use for the strict aseptic technique should be followed during the insertion as well as the maintenance. Matlab not only insertion, because some people are using the sterile technique only for insert and after that they are not at all using for the proper maintenance. That's why proper handling of the equipment and device is very important, because already I told all the neonates, all the NICU and PICU or maybe pediatric area also, because the babies are prone to get all the infection. That's why all the items those who are utilizing in that area we have to use in the sterile manner as well as maintained properly also. The next one is for the breastfeeding and immunity. So already I told the encouraging of the breastfeeding is very important, because already the starting breastfeeding is mainly important. It's present in the colostrum. At the same time, this breastfeeding will give a proper nutrition as the same thing is antibiotic. So this will support the baby immune system also. This breastfeeding already told the antibiotic and protect against the infections. So that's why maybe reduce the chance of the some of the sepsis and some of the gastrointestinal infections as well as the respiratory illness. But to prevent these important three aspects, sepsis as well as gastrointestinal infection as well as respiratory illness, we have to follow the proper or yearly breastfeeding system. This breastfeeding will give a more immunity to the patient. The next for the surveillance and monitoring. Surveillance and monitoring is nothing but routine surveillance, that is 24/7. Already we told that surveillance is nothing but we have to have a proper monitoring to the patients in the neonate 24/7 method till morning to evening. We have to see the proper, we have to check for the infection rate and what antibiotic they are using in the newborn care unit. So this we are following properly means automatically that will help to identify the patterns as well as the outbreak yearly. So that's why here we have to do for the vigorous monitoring. The essential newborn care recommends the wherever the NICU is there, PICU is there, we have to have a vigorous monitoring system. At the same time, how you are monitoring, according to that, we have to implement the corrective measures. Suppose something is going on wrong, so that time we have to implement the corrective measures immediately within the any unnecessarily failure or unnecessarily barrier will occur. So breaches is nothing but any failure occur, automatically the protocol maybe slight changes will you have to do. But the protocol in the sense maybe the steps you are not following, so then only maybe the mistake will happen. So that's why we have to follow the proper corrective measures. That is implementing the corrective measures immediately when the breaches in the protocol detected. Any barrier detected or failing to observe and we are not able to observe the proper that thing, we have to follow. So that's why surveillance and monitoring is very important. Next one is for the education and training healthcare workers. So here the regular training of the nurses, doctors and supportive staff in infection prevention control area. So it's nothing but education. Already we all people know Ganesh education we have to give, professional education we have to give, For like this is today we are that RK institution is organizing the 6th International Work Conference. That is also one way for the education. For the then and there we are improving the thing. So that's why including workshop or any practical demonstration or any competency assessment to ensure the updated infection control guidelines. Because for example, some people studied in 10 years back automatically, so they have to follow the proper guidelines, as well as if they are attending the training means automatically what will happen. So then and there they have to update their knowledge and have to deliver the proper guidelines to that area. So that's why continuous nursing education program is very important to update the knowledge those who are working in the hospital setup as well as the college setup also. The next one is for the family as well as the caregiver education. The educating patient and caregiver is very important, because why means they are only handling the baby and they have to follow the proper hand washing technique. At the same time, proper hygienic practice they have to follow, and we have to limit the visitors, because unnecessary visitors, if you are entering in the neonatal area as well as the PICU area, automatically what will happen? This is automatically the baby, because already the baby have a underdeveloped immune system, so that's automatically they will start with the help of the infection. So that's why the family caregiver education is also important. The family involvement is very important, and the family involvement ensure that continuity of the infection control practices even after the discharge of the hospital, because after discharge the family people only handle the baby. So that's why we have to proper education to the family as well as the caregiver, those who are handling with the baby. So that is very important. And after that, that is the essential newborn care equipment overview. So the vital means is very important. So very important equipment used in essential newborn care as well as the pediatric care. The first equipment mainly for the basic monitoring devices. So basic monitoring devices, or maybe we have to tell for the first line defense mechanism also we have to tell. So here the main thing for the basic monitoring means, if you are using for the basic monitoring, automatically what will happen? We have to have a yearly detection of any distress in the newborn. So if you are doing the yearly detection of any distraction, automatically what will happen? So this will improve the, or this will give a important to the baby for the timely intervention, at the same time to improve the outcome. So that's why yearly detection is very important. And next, so basic monitoring devices serves as the in any critical situation is a first line defense mechanism. So this provide the essential data. For example, pulse oximeter. The pulse oximeter, every people know, all the ICU, all the NICU, all the PICU is widely using. This will detect the continuous O2 saturation or monitoring, or giving immediate feedback of newborn respiratory status. So from that, automatically we have to have any early detection of the patient's any conditions. So next one is for the neonatal thermometer. So neonatal thermometer also is very important. So this will detect and maintain the optimal body temperature. Why means we have to prevent the hypothermia, or maybe we have to prevent the hyperthermia also, which can be dangerous for the neonates, that we have to identify with the help of the neonatal thermometer. So the pulse oximeter as well as neonatal thermometer, these two things, if you are using in the critical situation or in the ICU, automatically this will detect the condition easily. At the same time, we have to yearly detection, and we have to give a timely intervention for the patient as well as the neonate. And next one is for the oxygen supply as well as the lifeline of the newborn. So the action is very important. Those who are suffering from the respiratory distress, or maybe those who are in the ICU. So the action is mainly available in the primary sources as well as the portable sources. Primary sources means action, concentration, cylinder available, or maybe in the ICU pipeline. So this is a primary as well as important sources of the Indian NICU. So this is for the life-saving measures. Okay, the action is very important. So why here I am telling the portability means it's nothing but portable oxygen delivery system also. If suppose the baby in the remote area, critical care in the remote area, or maybe resource limited setting, or maybe we have to bridging the geographical gaps. Gaps means it's any villages. So that time we have to have a portable oxygen delivery system we have to take, and we have to complete the inpatient's care. So that's oxygen supply newborn is very important. This oxygen supply will help to survive the or lifeline of the newborns. Then next thing for the another equipment for the essential newborn care, mainly for the infant radiant warmer. So infant radiant warmer, every people know the radiant warmer is very important. So this is also one of the maintaining the newborn optimal body temperature immediately after birth, during the care also. At the same time, so this usually this they ensure all the medical staff or the nursing staff, they have to easily assess for the infant radiant warmer. So the infant radiant warmer will give birth and maintaining the baby body temperature. This is very important key equipment for the ENBC. The next is for the baby incubator. The baby incubator also mainly giving the sterile environment or maybe mainly giving the controlled environment as it is the baby present in the mother womb. Okay, like that, the baby incubator will give the warmth to the baby. So this is important for the premature baby or critical care infant baby. So baby incubator also very important. So this will give a sterile environment or maybe controlled environment as it is present in the mother's womb. This incubator will create the environment of the mother womb. So that's why this incubator will helpful for the premature baby as well as critical care infant patient. Next one is for the phototherapy unit. Phototherapy unit also very important. This phototherapy unit mainly we are using for the neonatal jaundice. So neonatal jaundice every people know. So this is only at birth itself it's coming. This is related to physiological jaundice. So here mainly they have to increase the bilirubin level. Total bilirubin level become increasing. So that time we have to treat for the neonatal jaundice. So here the baby is putting and the unit is delivering the specific light wavelength. So this light wavelength automatically to prevent the bilirubin buildup in the baby, as well as automatically this will prevent the brain damage also. If you are not keeping, suppose if you identify the physiological jaundice, if you are not keeping in the phototherapy unit, the baby will go for the potential brain damage also. If you are keeping properly in the phototherapy unit to prevent the bilirubin buildup as well as the prevent the brain damage also. These three devices is mainly important as well as cornerstone of the effective newborn care. At the same time, this will provide the critical support of the healthy baby to start a healthy life in the future. So these three equipment is very important as well as key equipment of the newborn care. Next is for the infant radiant warmer. So the infant radiant warmer is mainly giving, already I told this mainly giving for the efficient thermal regulation. Already I told now previous slide also the same way. This is the warmer is will give provide the consistent thermal support to prevent the hypothermia for the newborn without restricting the access for the examination as procedure. But if the patient in the radiant warmers, that time you have to do for the any procedure or any examination if you want to do. So that's why we have to do with the help of the radiant warmer also. The same time the radiant warmer will give a efficient thermal regulation also. And this warmer, this essential, this infant radiant warmer will give a widespread application of the any room, the delivery room or maybe immediate post-birth sterilization room or maybe some area. This infant warmer is fixed standard picture of the neonatal intensive care unit also. Why mean this three area for the for a very important area to maintain the ongoing thermal management for the baby. So that's why this widespread of application of the infant radiant warmer is very important. So this will spreading and covering the large area also. The large area I already told, delivery room for the immediate post-birth stabilization room or anyway, all the neonatal ICU also they are keeping for the infant radiation warmer. The next for the phototherapy also already told in the previous slides also. So this is very important for the neonatal jaundice because the neonatal jaundice is commonly affecting for the all the newborns only. If you are not untreated, it automatically go for the permanent brain damage. The newborn will go for the death. So that's why I already told the physiological jaundice, the neonatal jaundice is but not for the physiological jaundice only, not for the pathological one. Pathological is entirely different because pathological is due to any infection, but physiological jaundice means at the birth itself, the total bilirubin level become exceed for the 5 to 7 milligram per DL. So that's why if you are not treated that physiological jaundice is properly, automatically it will go for the permanent brain damage. The phototherapy unit is very, very important to combat the neonatal jaundice. The next one is for the baby incubator. Baby incubator is creating the safe environment as well as the safe of the second womb. It is like a mother womb only. The baby incubator is one of the foundation method. That is a basic as well as the fundamental in the care of the premature infant as well as the those who are in the low birth weight baby. So that's why we have to give a meticulously controlled environment we have to provide. So this is very, very important to direct the to delegate the environment of the baby. So that is very, very important. So in the baby incubator, what are the important is three things is very important. The mainly for the thermal control, next for the humidity regulation, and one is for the infection prevention. Thermal control is nothing but maintain the stable core body temperature. Core body temperature matlab, for example, we are fixing for the 100 or we are fixing for the 101 or maybe 98, 97 like that means. So this maintain for stable, the same temperature, what you are keeping the same temperature, it's maintaining for the core body temperature. So this is only mainly important for the premature infant, those who are suffering from the thermoregulation. Thermoregulation is nothing but whether the hyper or hypothermia. According to that, we have to identify and then we have to keep for the precise thermal control. The next one is for the humidity regulation. So humidity regulation is nothing but humidity mainly for to prevent the dehydration. Matlab to prevent the because automatically the skin tone and skin integrity automatically damage for the vulnerable newborn. To prevent that one, we have to control the humidity level because to prevent the degradation as well as to support the skin integrity of the vulnerable newborn. That is humidity regulation. Next one is for the infection prevention. Already I told we have to follow all the advanced filter system or any sealed environment to minimize the risk of the infection, and at the same time we have to follow the all the sterile technique. So that's why from the newborn care unit or any unit or maybe ICU, even adult ICU also, if you are following the any infection control protocol or maybe the hospital is NABH, automatically informed infection control nurse team will available or infection control team also available. With the help of the team, we have to design and we have to use for the all the sterile technique as well the all the sterile equipment or sealed environment we have to use. So then only reduce the risk of infection. At the same time, the environment become good. The neonatal mortality rate also become reduced. The next one is for the advanced ventilator. Advanced ventilator is nothing but excluding mechanical ventilation in some cases only. But in the small baby, mainly using for the non-invasive ventilation. So there is NIV. So this is device like a CPAP or maybe high flow nasal cannula. So this we have to use to gaining the all the respiratory problem or the baby in the any problem. So this is automatically with the help of the general respiratory support as well as without the intubation. But without the intubation, some of the non-invasive ventilation available. So this ventilation we have to utilize for the babies. Why means intubation is very, very because difficult for baby, and moreover we have to save the life. We have to use for the CPAP method as well as the high flow nasal cannula. We have to use and we have to offer in the general respiratory support without intubation. That is very important. Ventilator also important. The next one is for the infusion pump. Infusion pump is very, very important for the neonatal areas. So this is precision in fluid as well as medication delivery with accurate delivery of fluids, accurate delivery of the medication. So this is very important for the neonatal care. So that's why, because why means the baby size is the baby size is very important. That's why the tiny small size of baby, the body size become reduced. As well, at the same time, the baby is very sensitive to the physiology of newborns. That's why the infusion pumps provide and precise control to prevent the underdosing of the doses. So that's why any syringe pump we have to use, or maybe any volumetric pump we have to use. Syringe pump is nothing but we have to ideal delivering of the very small volume of the any doses, any injection or like that, small volume, because already told the body size is very small. This is sensitive to the physiology of newborn. So that's why we have to use for the some of the infusion pumps. So we, with the help of infusion pump, we are administering a smaller volume of the any dose, automatically that will give a high accuracy, and this medication will help to the baby also. The next one is for the volumetric pumps, means this is large volume of fluid to ensure the consistent and controlled the infusion rate. But like here the large volume of fluid means any NS or any oral or anything we have to give with the help of the controlled, matlab ensuring the consistent and controlled infusion rate. Matlab we have to set the infusion rate. For example, 14, 12, 10, like that we have to fix, and according to that we have to give the volume pump, volumetric pump. Syringe pump is different, only we have to use for the medication, and volumetric pump we have to use for the large volume of fluid like a IV fluids, like we have to give for the patient. That is a infusion pump. The infusion pump is very, very important to prevent the over or underdosing. Overdose also nahi dena chahiye, underdosing also nahi dena chahiye. So that's why we have to use for the infusion pump to prevent the overdosing or underdosing of the drugs or any fluids. And unnecessarily, if you are giving overdose or underdose, means automatically again the baby will undergo for the some of the severe consequences. That to prevent the severe consequence, we have to follow the syringe pump as well as the volumetric pump. Next one is for the other additional essential equipment, very, very important thing for the resuscitation trolleys and bag. So any resuscitation trolley as well as the bag, that's the emergency breathing support. So this will provide the immediate aid to the newborn with the respiratory distress. Then each trolley in ICU or any ward or a pediatric ward or any ICU or PACCU, that they have to keep any resuscitation trolley as well as the bag. So this trolley will equipped with all the important tools to prevent the respiratory distress. So that time we have to give for the proper intervention or rapid intervention to the baby also. And second thing for the weighing scale. The weighing scale is very, very important. Why we are giving weighing scale means with the help of weighing scale we have to monitor the baby growth. So once we are monitoring the baby growth means automatically we have to monitor the health status of the baby, and regular weight checkup is mainly and primary indicator of the newborn well-being only. Whether the weight is reduced, the baby weight is very, very important. With the weight itself we have to identify the baby healthy or unhealthy, as well as this is a primary indicator of the newborn well-being also. The next one is for the baby patient. So baby patient is nothing but safety and convenience purpose only. So this bassinet is one of the devices. So this devices is like a cart or something. So these devices will provide the comfort environment as well as the provide a secure environment for the sleeping for the newborn baby in the hospital setting. Often featuring maybe that I told accessible height or maybe accessible wheels, or this is very, very important for the mobility purpose also. There's a baby bassinet also very important, like a cart only. So the baby cot is very, very important for adjustable height also, or wheeling for mobility also. So this is very, very important for the additional equipment also. A trolley as well as the resuscitation bag is very important, and weighing scale is important, as well as baby fishing is very important. Okay, so this is the main and important overview of the equipment protocol for the essential newborn care. If you have any doubt, you have to ask question. Any doubt? So this is actually this essential newborn care already we are following in our day-to-day life. Those are working in the neonatal care unit as well as the pediatric ward. So this is a normal only already we know also. And even though I gave a even an overview of the essential neonatal as well as the pediatric care equipment as well as the any doubt for audience?
Thank you so much, ma'am.
Thank you.
Thank you, ma'am. We are truly grateful to you, ma'am, for sharing your knowledge and expertise with us all.
Okay, thank you so much.
So, participants, now we are beginning with our session 3 of day 3 of this international conference. And it's my privilege to invite our esteemed speaker, Dr. Dipesh Bharadwaj, sir, Associate Professor of Mahatma Gandhi Nursing College, Jaipur, Rajasthan. We warmly welcome you, sir, and kindly request you to deliver the presentation on emergency triaging assessment and treatment. Over to you, sir.
Oh, yes, ma'am. Can you hear me?
Yes, sir.
Share PPT. Hello, everyone. Myself, Dr. Dipesh Bharadwaj. Today, I give the lecture Emergency Training Assessment and Treatment. Next slide. So first, we are know about the trace. What do you mean the trace? Trace means the separated or selected. Selected, the child with the suffering from the severe condition, is a moderate condition, and the urgency care of the child. French word verb trial means the separate or selected. Trial is the process of rapid assessment of a patient with a view of defining urgency of care and treatment. And we are selected for this child who has requirement the urgency of care with the priority of treatment. It helps the rational allocation of limited resources and demand axial ability. Trial is the first step in the management of sick child in a hospital. The trial means collected and segregated of the condition of the disease and illness of the child. Next slide. Today we are the learn about the trial. Means the main objective of trial. The all sick children when they arrive in the health facility into the polyclinic, those with the emergency sign, those with priority of sign, those who are the non-urgent cases. So we are the three categories: red, yellow, or green. Means there is a higher requirement of emergency. They are the collected in the red signs, and then the priority, with priority base of care and admitted in the hospital and started the immediate care. So in the priority signs, and those who are the non-emergency cases, see the investigation and go to the home. Next, learning objective next assess the child airway and breathing and give the emergency treatment. Assess the child status of circulation and level of consciousness. Manage shock and coma and convulsion in the child. Assess and manage severe dehydration in the child with diarrhea. To try the condition, we are the assess child with the suffering from the breathing difficulty, any airway difficulty, and the circulation problem, level of consciousness, and the condition, the critical condition like shock, coma, and convulsion, the child, and many severe dehydration, either due to the diarrhea, any circulatory trauma for the circulation. Then we are the find out the level of consciousness. Step in the management of the sick child admitted in hospital. When the child go to the hospital, which kind of the condition we are the find of the child. So then we are the check the emergency sign, check the primary sign, and third one non-urgent cases. We are the all three conditions, and we take the history and examination of the child, laboratory and other investigation, and the in the emergency, we are the give emergency treatment. List and consider different diagnoses, find out the diagnosis problems treated by suffering from the child, and select main working diagnosis and secondary diagnosis. And we will start the treatment according to the condition with the priority of care, the emergency of care. If he is needed admitted to the hospital, we admit as soon as in the hospital's ward. Triage. Triage is the sorting of patient into the priority group according to their need and the resources available. So the main objective of this condition means find out and select the condition. Which category are divided the children. So mainly we are collected child in the hospital who suffering from any condition, emergency sign, priority sign, and non-urgent cases. In the basis of this condition, we are the provide the care and the resources available to immediately provide the care of the children. EPQ. It is a E emergency, P priority, Q and Q not urgent. We don't need the urgency for the treatment. Priority P means we the care. We are the priority basis provide the urgency. And emergency means the critical condition of the child. If they are not, we are not provided any care of in emergency situation, then the death of the children. So emergency cases need immediately emergency treatment. Priority cases need assessment and rapid attention. And non-urgent cases can wait their turn to the queue. Emergency sign, the ABCD concept. Find out the ABC. ABCD means airway, breathing, circulation, consciousness, convulsion, and D means dehydration. And easily remember as ABC. In the trial, we are the patient involved looking of signs of seriousness illness or injury with the symptoms of ABCD. We find out the children airway, breathing, and circulation or dehydration. Then we are the give care and the EPQ. We selected and the child emergency care, and the primary care, and the non-requirement care. Beside the group of emergency sign described here, they are the priority of sign which should alert you to the child who need promote but not emergency assessment. These signs can be remembered with the symbols of 3 EPR MOV. The priority signs for the emergency and the priority signs we are also included 3 EPR or MOV. Next slide we are the described 3 EPR and MOV. 3 TPR the 3 TP, T means teeny baby and is child age under the 2 months. And next T means temperature, change the temperature, child is very hot, very cold, condition of hypothermia. And third T, trauma, any trauma or other urgent surgical condition. So 3T means teeny baby, temperature, trauma, and the P, 3P, pallor, poisoning and pain. With condition of sinuses and condition of any poisoning and the condition of severe condition of pain. And 3 are in respiratory distress, restless, continuously irritable or lethargic. Or urgent, the care provided for the urgent cases. And MOV means malnutrition, any sign of the visible severe malnutrition, the PEM, severe fasting, and the sign of the edema, accumulation of fluid, any part of the body, and burns. In the cases of burns, we have found the degree of burns and provide the care with the emergency priority of none. Next slide. The triaging process. Triaging process when started. The triaging should not take much time. We are not sure that we should not take more time for the care of children. For the child who does not have emergency time, it takes an average 20 seconds. If the child does not have emergency time, then we take some time. But in the emergency care, we don't waste any time. The child who is smiling and crying does not have severe respiratory distress, sober coma. The child with the good cry and no sign of their symptoms, any distress, their airway, breathing, and any respiratory distress, any sign of shock and coma. And the health worker looks at the child after the observation. The health worker looks and they looks the child is very well. The chest for breathing and primary signs such as severe malnutrition and distance to the abnormal sounds in the speaker and breathing. In the priority basis, we have to find out any extra sounding, the respiratory cerebral sounding and breathing sounding, breathing sound, any abnormal sign, we carry to the child in the priority care. When and where should triage take place? Means when we are required the triage care, so triage care should be carried out as soon as the sick child arrives in the hospital. When the sick child arrives in the hospital, this should be the started the care. Then before any admission process, such as the visitation. Means after the visitation, we started the care. Triage is carried out the different locations in the outpatient tube, in the emergency room, and in a ward. If the child has been brought directly to the ward at night, in some settings, try that in all these places. In we are started the care anywhere. Anywhere means if the child is admitted in emergency or any general ward, or any outpatient department. When we receive the child, we are starting to the care. Who should try? Try कौन सेपरेट कर सकता है, कौन उनको दे सकता है? Our clinical staff, the clinical staff included in the hospital, health worker, nurses, and addition such as people, gate man, report clerk, cleaner, etc. Means who are the available during the time of the admitted in the child. We are those are the person are included in care of the child. How to triage? Find out the condition of this triage. Keep in mind the ABCD. We are before airway, breathing, circulation, coma, dehydration. To assess if the child has airway or breathing problem, you need to know: is the child breathing? Is the airway obstruct? Is the child due? We are the find the condition of ABCD. The pattern of airway and pattern of the breathing, child breathing pattern, the rate of the respiration more than 50 more less than the 20 15 condition of breathing, and any obstruction of the airway we find out due to the injury, trauma, we are the find obstruction of airway and the cyanosis, the circulatory loss. Is the bleeding anywhere? The condition, the child condition is due, find out the signs. Assess if the child has the airway breathing problem. If we have the condition of airway or breathing problem, so we are the look, listen and feel of air movement. Obstruct the breathing can be due to the blockage by the tongue, a foreign body particles, a swelling around the upper airway. That to take access or severe foot disease which may be present in the means looking at the child and finding out the condition which problem are create the obstruction in the breathing. There are some example blockage in the backward the tongue, then the blockage of the laryngeal and the foreign particles are obstruct the condition and the any swelling around the airway. Does the child have severe respiration? If the child find out we are the assessment respiration, the child having trouble getting the breath so that the difficulty to talk, eat or breastfeed. Is the breathing very fast and getting tired? Does he have severe chest drawing or is the using regularly respiratory muscles? Where after the assessment, assess if the child has circulation problem, does the child have bar? We are the touch the child body and find out any situation of the bar. If not, if the capillary defect time longer than 3 seconds and the pulse weak and fast. If we are trying to feel the pulse, any condition, we have to find pulse line and any fast condition. The rhythmic situation are very fast. In the older child, the radial pulse may be used. We are the radial pulse to feel the condition in the older child. If the child is infant, brachial or femoral pulse may be needed to be felt. In the infant child, we are the fine pulse with the femoral pulse or brachial pulse. To assess for coma, you need to know a rapid assessment of consciousness level can be made by assessing the patient one of the AVPU category: alert, respond to voice, respond to pain, and unresponsive. We these four conditions we are the assess coma condition. Means level of consciousness. With the alertness, if the child we are the pinch, any sound, here, as the child speech, chin, we are the alertness. And respond to voice. We are the call to the child, the name, the name of the child. If the hear response, we are the check and pain. Pain, we are the provide stimulation to the child. If he hear with the response, he unrespond. Or you unrespond. Means there are the no alertness, no response to our voice, and no response to the pain. So then we are the child in a coma condition. And also we are the found heat dehydration. You need to know to if the child is lethargic or consciousness, we are the child skin conductivity and the activity of the child. If the child is lethargic or unconscious, the sign of dehydration. And if the child eye is sunken, we are the sign of dehydration, sunken eye. And if the skin means go back to the very slow, means skin conductivity are very slow. If we pinch the skin and backflow the skin go slowly. So the sign of dehydration. When the ABCD has been the complete, then there are no emergency signs continue to assess the pregnancy. So first we are the find emergency sign. We are the investigation. We are our assessment. First based on the emergency. In the emergency, we are found on the ABC, airway, bleeding, circulation, and last one the dehydration. If there are no emergency signs, then we go to the assessing the priority. Child step D when sign is positive. Assess ABCD which condition we also already read. If positive, B. If negative, proceed to B. Means if the airway problem, if there is a positive sign, then we have to start the treatment. If it is negative, so the second one we have to start with the B. If the bleeding problem, if the bleeding problem is positive, then we have to start treatment. If the bleeding problem is normal, there are no sign of the bleeding problem, respiratory distress, and then we proceed to the C. After the C, we also check the circulation. If the circulation is slow, any collapse, any diagnosis condition, then we will be the start the treatment. If the condition is negative, means there are no sign of the circulation collapse and no sign of any sinus. Then we are the started the see the decondition. After the decondition, the sign of the dehydration. If there are no dehydration, we are found that there are no other sunken eyes, there are no skin ability loss, then we will be start first to the priority sign. After the emergency, we are the going for the priority sign. Next, priority sign. Next slide. Please next slide. Go to the next slide. Once appropriate emergency treatment have been initiated after the ABCD condition of the any emergency cases, we are going to the priority care, call for senior health worker, draw blood or emergency laboratory questions such the blood glucose, hemoglobin and malaria senior, and ask for the head of neck trauma before providing the treatment. Take careful note if the child is severely malnourished. The appropriate treatment of the emergency with the care of started of priority. When we just check any trauma in the head, any trauma in the neck, we are to find out the condition with the fully observed of the child. If the child is severely malnourished, we are to started immediately care of nutrition. Next slide. Next slide. Airway breathing and airway or
Hello,
breathing
sir.
problem. Airway and breathing or breathing problem. Life receive attention before you move on. The first time we are the observe airway and breathing. If any airway breathing problem, it is a life-threatening condition and children may be go to the coma. So we are the priority the first attention to the airway and breathing system. Then other system. Sorry, due to the technical problem, next we are the start of management of ARV. Management of the choking child. If the child is choking, do not hesitate or for the ARV according to the restriction and the age group. If we are the found any choking condition of the ARV, we immediately manage this problem. There are calls for the physician and surgeon for according to the condition and instruct to the age group. Management of the younger infant and management of child. The management of young infant, lay the infant on your arm or thigh to head down the position. In this kind of position, we are the manage the child in the give the 5 kilo infant back on the heel of hand. After the taking of suspension of child, we are the back slap for the stroking condition. After the back slap, we are the starter child turn. Means to the condition of solve of choking. If the obstruction is persistent, after this procedure, obstruction is persistent, turn infant over in 5 with the 2 fingers. In the diagram, we are the third with the 2 fingers in the condition of choking. That management of young child. If management of young child, we are the condition slapping the back to clear ARV obstruction in the choking child and handling maneuver in the choking order. This is the condition of like the lifting of the child. If height no back is a heel of hand and child is sitting heel or back, we take a child with our knee and thigh and slapping in the backside in older child and handling maneuver in the choking order to child for the choking condition. You should first open the airway and the breathing giving the child. Notice position of the parent infant and motion we are the up of the child chin and up of the nose to the clear of airway. Sleeping position to open airway in older child is condition for clearance of older child. How to manage the airway in a child often breathing who are the just stop breathing. Means these conditions are position for the child who have just stopped breathing and maybe the flow of the breathing pattern. No neck trauma is suspected. We are the found trauma in neck. If we are found any trauma of neck, we are the support of the neck. Neural position, inspect mouth and remove foreign body if the present. If there are any foreign particles in the mouth, we are the immediate remove these particles. Clear secretion from throat, any secretion of throat, we are the clear of the child. And if the child is unconscious, tear the head up to the head condition. if there is a possibility of neck trauma, we are the bound any trauma of neck. We are the support neck trauma to open and manage airway when trauma is suspected that from is the condition and the job has with a hold until this is the opening airway without neck is condition when the neck trauma. Neck trauma is suspected, sterilize the condition with the straightforward with the jaw. And the same figure are sterilize the neck when trauma is suspected. After the observation, we found the any trauma and with overweight and suspected, then we will sterilize the patient and this condition with the tools supporting cotton roll, cotton ball, we have small probe and bind with the child base. How to position the unconscious child? If the child is unconscious, turn the child on the side of reduced risk of activation. Left lateral position to be given. The respiration problem. Keep the neck slightly extended, sterilize the pitching of the chest. Diagram is for condition. How to be create and if the child is suspected of the neck trauma. Management of breathing problem. Ventilate with the bag and mask. If the child is not breathing after of the airway ventilation, self-ventilation, bag and mask, it is condition. Ventilating is ready with the self-filling mask. We are using the Opioid, Opioid and provide the artificial ventilation. If we are the provide with the oxygen mask, so there are four figures. The first figure is right position, means correct size and correct position of mask. We are check the mask is proper with the cover of both nostrils and mouth. Okay, the second condition is the wrong mask position and mask is too large. The diagram we are show mask down the chin, mask too small, and the third condition mask is small, only cover the mouth. There are the both included nostrils, and the fourth condition. This may be also wrong condition. He also included the eye. Mask is too large, ज़्यादा बड़ा है, large है, and cover the eyes, chin, nostrils, and cover the chin. So we are the so condition. First is priority basis, correct mask and correct position. If any problem, we are the orange pharyngeal. We have the many types of orange pharyngeal according to the age of condition, age and condition of the children to improve the airway opening. Figure number 130, selected the right type of an orange pharyngeal airway. We are the measurement. After the measurement, we are the condition size of the orange pharyngeal and instruct the orange pharyngeal in the concave side and concave side up and turning it around. Then the any condition of obstruction we are the solved. And last one, we give the oxygen. For all children who have the problem with their airway and breathing, all will give oxygen first. While we continue to assess the other problem, central sinus is sign of deficient oxygenation, desaturation, and children need oxygen again. However, children who are anemic and desaturated may not show signs but also need oxygen. Means we have the standard for giving the oxygen. That's the signs for central sinus. The central sinus look at the mouth and tongue. We have the so in the diagram, lips, tongue, mouth area, use calculation. This for the central sinus. The later is the ABCD stand for the circulation, assessment, management of coma and convulsion. With the experience, you can assess the emergency signs very quickly, almost instantly. You can recognize some immediately such coma and convulsion. We are the next slide. We have found a condition of coma and convulsion. This is the assessment of circulation. The cold hand is the capillary cell longer than 3 seconds and peak and fast. We assess if the child is cold activity due to the lack of circulation in the body, and pulse may be weak and fast. There is a sign of circulation dysfunction. So, the most common cause of shock in children is due to the loss of fluid from the circulation. The main sign in the children for the shock, loss of fluid in circulation, eyes close, loss of the body, severe diarrhea, and when the child is bleeding or shock apparently leak the disease such as severe dengue fever. This is the sign of shock. If the child has diarrhea, if the child is bleeding, and any capillary leak, and also loss of circulatory fluid. In all cases, we immediate treatment to release the fluid quickly. If the child has severe malnutrition, you must use a different fluid and different rate of administration and monitor the child very closely. Treatment of shock. If the cold hand capillary cell time more than 3 seconds and fast to pulse, then she be in the shock condition. Then select the appropriate site of administration of fluid, establish IV or intraosseous assay, take blood sample, emergency laboratory test, and start the care of for severe malnutrition also. How to give IV fluid rapidly for shock in children with severe malnutrition? If the child is severely malnourished, the fluid volume and rate are different. So, check the child is not severely malnourished. There are the chart also included maintenance fluid. If the child has no severe malnutrition, give 17 ml kg of single solution. If not available, give the normal solution. Over 5 hours, age below the 12 and the 2.5 hours in children age of over the 12. There is the assessment of the malnutrition and dehydration. Assessment of coma, also be AVPU, same condition for the alertness, of the voice, and of the pain and unresponsible for any voice or condition, any stabilize and feel the change and sign of the unconscious. Child may be lethargic, unconscious, and coma state T or you will receive emergency treatment for coma. Assessment of convulsing. Child must be seen to have convulsion during the night process while getting the observation department. The assessment depends on the observation of the child, the treatment and observation. Coma वाली condition है. If the child is unconscious, you should manage the airway, position the child, and take the history of trauma and exercise. Check the blood sugar and give IV glucose. In the condition of convulsion, if the child is convulsing, now you must manage the airway, position of the child, check the blood sugar, blood glucose level, and give IV glucose, give anti-convulsion drug. This is a treatment of during the condition of coma and convulsion. Position of the unconscious child for the early recovery. Check the blood sugar, coma and convulsion, where blood glucose can be obtained quickly. Then should be the started gastritis, hypoglycemia is the present. We are the starting glucose and for the age of the children and condition of the children. Coma and convulsion, IV glucose, IV and should be started. Give 5 ml per kg, 10% glucose solution rapidly by IV injectable. Recheck the blood glucose level in 30 minutes. If it's still low, please 5 ml per kg, 10% glucose solution. Feed the child as to consciousness. If the child is not able to feed without restriction, highly fluid containing 5 to 10% glucose or restored base sugar solution by fluid. If the child are not able to take with the mouth, we are starting with the feeding of pediatric to feeding method. How to give an anticonvulsant? We are give the diazepam to stop convulsion. Diazepam can be given by the rectal intravenous route. Rectal diazepam can be given 2 to 4 minutes. In emergency, it is the easier to give it rectally given the intravenously unless an intravenous is already available. The dose of diazepam 0.5 mg per kg rectally or 0.5 mg per kg intravenously. They are to reduce the conversion with the addition of diazepam anticonvulsant drug. There are two different routes, rectally or intravenously. The dose are different with the rectum and intravenous. After this procedure, we check the child for the 10 minutes for the stabilization of the any convulsion. Second dose, we are starting if the convulsion is not stopped. If the convulsion continue, then switch to the second dose. Then the third dose can be given. After the first 10 minutes, last one, third dose given with the alternative dose. IF or IF can be used. Recommended dose 15 to 20 mg per kg. The dose will be the increase. In the condition of dehydration, assess the condition of child. If there is no sign of dehydration, child move to the priority of care. Severe dehydration, assess the severe dehydration. You need to know child lethargy, sunken eye, and skin colorability. There are the formulas to assess the dehydration. If severe dehydration, child has also history of diarrhea, that is a positive sign of dehydration. Dehydration may be condition, lethargy, sunken eye, very slow skin pain, and also with the severe diarrhea. Treatment of severe dehydration: give the child large quantity of fluid to be first portion of IV fluid 30 ml per kg given very rapidly, and after this 70 ml per kg given more slowly to complete the dehydration. In all cases of the fluid choices during the selected. In the dehydration condition, we provide the RN for the children IV method. And also given the ORS IV per kg every hour to dehydration. We give the calcium ORT, oral dehydration therapy, and we give oral dehydration solution in to prevent dehydration condition. If the hydration is not improving, if the IV drip more rapidly, we observe the child continuous and monitor. If the hydration is not improve, then we will be starting IV drip more rapidly. Also give ORS solution as soon as possible. If the child can drink, we usually 3 to 4 hours in infant or 1 to 2 hours in older children. We assess the 6-hour infant and after the 3 hours older children. Severe dehydration with the severe malnutrition, do not give IV fluid if possible. The maximum dehydration fluid should be given orally by the neonatal tube much more slowly than you would can dehydration of this children. And assess the child continuum with the blood sugar level and the condition of malnutrition. If the better give 10% glucose to a child whose sugar is borderline with the murder, and the dressing oil with the 2 and 4. Treatment of severe dehydration. Does the child have shock? Is yes. See treatment of shock. We are starting with the dehydration and also shock treatment. In this condition, if no, give the ringer lectin. RL will be started if if there are no condition of soap for infant and older child, doses are different. Assess the child every 1 to 2 hours. Assess the child of dehydration condition and improvement. Give the most fluid to bleed. Severe dehydration. My mechanism to if the child has no severe malnutrition, give the 70 ml per kg renal lactate solution, or if there are no available, give the normal time. Over 5 hours, infant age less than 12 months, and over the 12 months, there the dose are divided with the time management with the 5 hours and 2 and 1 hour. And ORS solution are given for the children according to the condition, and 3 and 4 hours in infant and 1 to 2 hours in children. And if possible, we encourage the breastfeeding to reveal malnutrition condition, dehydration condition, and also the diarrhea condition. So this is the management of child needs. Separate or selected. Separate selected with the 3 conditions. The 3 conditions are emergency, priority, and non-urgent case. Thank you. Any doubt, any question about this topic? Any questions?
Thank you, sir.
Any question?
Thank you so much, sir, for your valuable insights and contribution to this session.
Thank you.
So participants, we are now proceed to session 4, and this session is focused on legal and ethical perspective of palliative care. And for this session, we are honored to have Dr. Sheetal Bhade ma'am, Principal cum Professor of Bapu Saheb TJ College of Nursing, Pune. We welcome you, ma'am.
Hello.
Yes, ma'am.
Yeah, I'm audible, right?
Yes.
Yeah, I'll just share my PPT.
Okay, ma'am.
Is it visible?
Yes, ma'am. It's visible.
Yeah, okay. Okay, so good morning everyone. I'm Dr. Sheetal Bhade. I'll be dealing with the topic that is legal and ethical issues in palliative care. So when we talk about legal and ethical issues in palliative care, being a nurse, it is our role to protect the rights of the patient, especially when the patient is into a palliative care. So basically, what is our role is we have to balance our compassion, we have to protect the rights of our patient, and we at the same time we have to fulfill our responsibilities as the nurse also. To start with, palliative care is a holistic, patient-centered approach to healthcare that focuses on improving the quality of life for individuals with serious chronic or life-limiting illnesses. So basically, we are giving a holistic patient care to this patient who are at their end of life situations. Unlike curative treatment that aim to eradicate the disease, what palliative care does, it basically emphasizes that we know that we cannot cure the patient at this stage, but the main emphasis here in palliative care is to relieve the pain of the patient, to to relieve his distressing symptoms while also addressing the emotional, social, and spiritual need of the patient. It will also it also support not only the patient but also their families. Like along with the patient, the family is also going through a grief of losing someone very important. So we have to also take care of the family members. We have to ensure their dignity at the same time. We have to respect them and we have to comfort them throughout their illness trajectory, including the end of life care. So that is what all we are going to see in palliative care today. So coming to the definition of palliative care, according to World Health Organization, palliative care is an approach that improves the quality of life of patients and their families facing problems associated with life-threatening illness through the prevention of relief of suffering by means of early identification, assessment, and treatment of pain and other physical, psychological, and spiritual problems. So basically, what we are trying to do in palliative care is we are not here to cure the patient, but we are here to elevate the suffering of the patient. We are here to give a good end life care to the patient. We want to relieve the patient from the pain, for which we have to do an assessment of the patient, identification of the symptoms, and symptomatic treatment has to be given to the patient in this situation. Now, what are the goals of palliative care? So we all know now what is palliative care, but why do we give this palliative care to a patient with chronic illness or a life-threatening illness? So the first goal is relief from pain and symptom. As we know, just take an example of a cancer patient who is into the last stage of cancer. The kind of pain the patient is having, that will worsen the condition of the patient. So in palliative care, our first goal is to relieve the patient from this pain. So how can we do that? We can manage the physical discomfort such as pain, breathlessness, fatigue, nausea, or insomnia of the patient, and improve the daily functioning and comfort of the patient, which will again improve the care of the patient. The second goal of palliative care is we have to enhance the quality of life. So whatever life is remaining, we have to make sure that quality of that remaining life is enhanced. How we will do that? We can do that by focusing on the on living as fully and meaningfully as possible despite the illness, and we have to encourage the patient in daily activities and decision making for themselves. Then the third goal of palliative care is providing spiritual and social support. So that is something which is very important when it comes to palliative care. Spirituality, because people who believe on spirituality, they really feel when they go into spirituality, they feel so much of relief, as well as social support is very important. So we have to make them attend to some spiritual meetings, and then we have to strengthen their social connections also. Social connection, if we will strengthen, there will be no feeling of isolation. They will be always surrounded by people. Then the fourth goal of palliative care is support for patients' emotional and psychological needs. So as already the condition is so distressing for the patient, they are already in a emotional turmoil, and they have so many psychological needs at this time, at this period of time. So what we need to do is we have to address their anxiety, depression, and fear whatsoever they are having at that particular time, and we have to promote their coping mechanism, and we have to help them to rebound back to the normalcy, to live a good quality of life, whatever life is remaining. Then the fifth goal of palliative care is respecting autonomy and patient choices. So we have to uphold the patient's right to make informed decisions about their care. That is another goal of palliative care. The next goal of palliative care is supporting the families and caregivers. So when we talk about palliative care, it's not just giving care to the patient, but at the same time, you also have to take care of the family, because they are also into a process of grief. So what we can do here is we can provide guidance, counseling, and education to the caregiver, and we can even offer bereavement support after the patient's death. The next goal is facilitating a peaceful and dignified end of life. So here ensure dignity, respect, and comfort in the final stage of life and avoid unnecessary interventions that may prolong the suffering. So we will not do any kind of interventions which will prolong their suffering. That is what it means here in facilitating a peaceful and dignified end of life. And the last goal of palliative care is promoting interdisciplinary collaboration. So as we all know, when we talk about nursing care, it is not just a nurse who is caring for a patient, or it's not just a doctor who is caring for a patient. It is an interdisciplinary collaboration. So same comes in palliative care also. Here also we encourage teamwork among the doctors, nurses, counselors, social workers, and spiritual leaders, and also deliver holistic care through shared experiences. So that was all about the goals of palliative care. Coming to the importance now. So that was just to start with the legal and ethical consideration in palliative care. I have just given you a brief introduction about what is palliative care and what are the goals of palliative care. Now let's talk about what is the importance of legal and ethical considerations when it comes to palliative care. So the first important consideration is protecting the patient's right. Here is where the legal and ethical points plays a very important role. So we have to ensure the dignity, the autonomy, and the informed decisions of the patient. Here we have to see that we are not violating the rights of the patient. We are doing as per the will of the patient. That is very important here. Second is ensure safe and compassionate care to the patient by promoting pain relief and quality of life without any kind of unnecessary suffering to the patient. Then the next importance is guiding end of life decisions to the patient. So here we can help in making fair choices about life support, resuscitation, or comfort care. So we can help the patient to take his own decisions about the end of life decisions, like whether we have to give them resuscitation when it is needed, or what kind of comfort care we need to provide them, or we don't need to provide them. All this kind of decisions we can help the patient to take. Then support families and caregivers. So here we have to reduce confusions and conflicts and emotional burdens. So many times family members are into so much confusion at this end of life, taking end of life decisions. Like a patient is in a vegetative condition, there is no improvement, there is not going to be any improvement in the patient, and the family still doesn't want to remove the life support system here. So this kind of decisions are very confusing and conflictable decisions. So here we have to support the family members and the caregivers in taking their decisions. Then the next importance is prevent ethical dilemmas. The legal and ethical considerations also help you to prevent any kind of ethical dilemmas while taking decisions in these situations. So basically, we have to provide very much good clarity for healthcare teams and families when there are chances of conflicts while taking decisions in this time. And last is protect the healthcare providers legally. So we as a healthcare provider should also not get into any kind of conflict. That is also one of the very important concept when it comes to legal and ethical issues. So here we have to safeguard the doctors and the nurses by following all kind of legal frameworks which are given in for the palliative care and end of life decisions. Now coming to the ethical principles which we need to follow in palliative care. So the first, now we all have gone through this ethical principle. So just to refresh it, the first ethical principle which also has a very important role in palliative care is autonomy. What is autonomy? Autonomy is respecting the choices of your patient. So let's take an example here in palliative care. What can be an example of autonomy? A patient with advanced cancer, he refuses for further chemotherapy and chooses only comfort care. The healthcare team respect this decision even if family members want an aggressive treatment. So there where autonomy plays a very important role. Sometimes the patient doesn't want to go through all that pain, right, and all that suffering. So they just take a decision that I don't want to take the chemotherapy further. I just want comfort care or supportive care till the end of my life. And though the family members want the patient to take the treatment, but still the patient is not willing to do so. So here we have to respect the choice of the patient. That is what autonomy says. Next is beneficious. What is beneficious? It is acting in the patient's best interest. So example is a nurse provides effective pain management and counseling to ease a patient's suffering even when curative treatment is no longer possible. Though we know that at the end can do to make the patient at ease, whatever we do that will come under beneficence, that is acting in the patient's best interest. The third principle, that is non-maleficence, that is do not harm your patient. That is also very important as a healthcare provider. So example is a doctor avoids prescribing unnecessary invasive procedures that would prolong the suffering without improving the quality of life. So when we know that providing any kind of further procedures will also not improve the quality of life of the patient, then we should not or a doctor should not prescribe, or we should not provide any such kind of care to the patient which will increase the suffering of the patient. So following this principle is non-maleficence principle. And the last is justice, that is you have to be fair and give equitable care to your patient. Like for example, a government hospital ensures that both poor and wealthy patients have equal access to free pain medications and palliative services without any kind of discrimination amongst the patients. So these are the four ethical principles which are very important in palliative care. Now, what are some common ethical issues? Coming to the ethical issues which we really feel we face when we are going through a palliative care plan for a patient. So, the first common ethical issues which most of the healthcare professionals face or a healthcare organization faces, withholding or withdrawing the life-sustaining treatment. So basically, what does it mean? It means deciding not to initiate or to discontinue medical intervention such as ventilator support, dialysis, or artificial nutrition or hydration when they are unlikely to improve the patient's quality of life. So we have seen such kind of patients in hospitals who are into a vegetative state where there is no improvement which is going to happen in the patient. So here the most important decision which the family members has to take is whether they have to withhold or they have to withdraw the medical interventions which are there supporting the patient. So now what is the ethical consideration which we have to think of here is not the same as euthanasia. It is not euthanasia, you are not killing the patient over here. The intent is not to cause the death but to avoid the prolonged suffering of the patient. So where here we have to basically focus on the comfort care and dignity of the end of life. So like example, there is a patient wherein there is no improvement in the patient and there is no chances of improvement in the patient. So we stop the ventilator support for this kind of terminally ill patients where there is multiple organ failure, and we already have discussed all these situations and conditions with the patient's family, and with the mutual decision we have mutual understanding, we have come to a decision of withdrawing or withholding the ventilator support of the patient. So this kind of decisions are called as the withholding or withdrawing life sustaining treatment. So that is one of the ethical issues, common ethical issues which occurs. Then the next common ethical issue which can be seen is informed consent and decision making capacity. Again, very important, informed consent and decision making capacity. So it means patient have the right to receive complete information about their illness and treatment options and to make voluntary choices if they are mentally capable. So whenever we are doing any kind of treatment for a patient, or we are going to do any kind of procedure on the patient, first thing is to inform the patient about the procedure and to take the informed consent of the patient. If the patient is able to make his own decisions, he is in the mental capacity of taking the decisions. Here what we have to consider ethically is capacity assessment is essential, whether the patient is able to understand what is going on, whether he is able to retain it, and whether he is able to understand how important it is. So weighing the information. And the another point where we have to think ethically is in cases where the patient lack capacity of decision making, we have to take a surrogate decision maker, that is a family member, blood relation or blood relative of the patient who can take decisions for the patient. So the example of this kind of decision making is a patient with advanced cancer choosing palliative chemotherapy after being explained both benefits and side effects. So that is another ethical issue. Coming to the third kind of common ethical issue which we face during this condition is truth telling versus maintaining hope. So as we all know, when it comes to palliative care or end of life care, this kind of breaking this kind of news to the patient is a very difficult part of our duty. So basically, when we talk about truth telling or maintaining hope, it is balancing the ethical duty of honesty, the need to preserve a patient's emotional well-being and hope also. So we cannot tell the patient dishonestly about his illness. We have to tell him honestly what the patient is going through, what is the condition of the patient, but at the same time we have to maintain the emotional well-being of the patient also, and we have to keep some kind of hope also in the patient. So that is what it means. So what we have to consider ethically here is full disclosure promotes autonomy. So we have to do full disclosure to the patient here, which will promote full autonomy to the patient. He will be able to take his own decisions as per the patient's readiness and cultural background. And sometimes a gradual or compassionate disclosure is also preferable. Sometimes you may not be able to tell the patient everything at one time. So slowly you have to tell the patient about his illness. So the example here is what I'm trying to explain you is, instead of bluntly saying you will die in a week, the doctor may say that the disease is progressing and we will now focus on comfort and quality of life. So that can be a way of conveying the truth to the patient. The next common ethical issue is the cultural and religious values. So here, basically, the patient and families may make healthcare decisions influenced by their cultural traditions and religious belief, and we have to respect this cultural traditions and religious beliefs here. So what we have to ethically consider is respect for the diversity during the palliative care, and some cultures prefer non-disclosure of diagnosis. Some religious beliefs may prohibit life stop life support, stopping life support. So we have to respect their decisions here as per their cultural values and religious values. So, for example, what we are trying to understand here is a Hindu family requesting a spiritual ritual before withdrawing the treatment, or a Muslim patient requesting a specific end of life practices. So what we need to do is here, as a healthcare professional, we have to respect their cultural and religious values and do the procedures accordingly. Now coming to the legal considerations. What are the legal considerations? What we have to take care during the palliative care is, first is the advance directives and the living wills. We have to always consider these things while taking decisions for this end of life care of the patients. So what is advance directives and living wills? It is a legal document in which a patient outlines their preferences for medical treatment in case they become incapable of making decisions in the future. So they make their will about their medical decisions in advance only. What is the purpose of this kind of living will? It ensures that the patient wishes are respected, and even when they cannot communicate. So even at the last stage when the patient is not able to communicate or make decisions at Yeah, hello.
Yes, ma'am.
Yeah, sorry, I got disconnected. I was not knowing. Can you just tell me from which slide I got disconnected?
Yes, ma'am. From the show only.
This only? Okay, okay.
Yes, ma'am.
I'm audible right now, right?
Yes, ma'am.
Okay, okay. Okay, so we were talking about the legal considerations here. So in the legal consideration, the first point what we have to follow is the advance directives and living will. Now, living will are very common nowadays. What does it mean? It means a legal document in which a patient outlines their preferences for medical treatment in case they become incapable of making decisions in the future. What is the purpose of this kind of wills? It will ensure the patient wishes are respected even when they cannot communicate. It is very important. So example is a patient with a progressive dementia writes a living will stating they do not want ventilator support or CPR in the event of cardiac arrest. So this kind of living wills are very common nowadays, wherein the patient writes in advance that what kind of end of life care they prefer to have. So that was the first legal consideration. The second legal consideration is do not resuscitate orders. So what does it mean? It is a medical order that instructs the healthcare provider not to perform cardiopulmonary resuscitation if the patient's heart stops or they stop breathing. So now what is the purpose of such orders? It prevents unnecessary or burdensome intervention in terminal or end stage illnesses. So this kind of orders are also given. Here, a terminally ill cancer patient signs a DNR order. So doctors focus on comfort care instead of aggressive CPR that may only prolong the suffering of the patient. So that kind of orders are also signed by the patient beforehand. That is another legal consideration which we have to keep in our mind in palliative care. The third kind of legal consideration which we have to keep in mind is guardianship or surrogate decision making. So, what is it? It is when the patient lose the decision making capacity, a legal guardian, which is also known as surrogate, oftenly this kind of person is the family member of the patient. He is authorized to make healthcare decisions on the behalf of the patient. That is what guardianship or surrogate decision making means. Now, why it is important or what is the purpose here in legal consideration? So, it ensures continuity of care and protection of the patient's rights when the patient is incapacitated. So, here, when the patient is not able to take the decisions for his own, the family member will take the decisions for the treatment of the patient. That is the importance of this guardianship here. Example of it is unconscious stroke patient's daughter, who is the legal surrogate of that patient, decides to withdraw the ventilator support based on what the patient has previously expressed. So, in such conditions, this surrogate decision maker or a guardian can take decisions for the treatment of the patient. So, that is another very important point. Coming to the next legal consideration, that is the legal framework which governs the end of life care. This is again very important. Being a healthcare worker, we should know what all kind of legal frameworks are available while caring or while being into this healthcare profession and caring for this end of life care patients. So, national and institutional laws, policies, and ethical guidelines that regulate the palliative care and end of life decision makings. That is what is this legal framework which governs the end of life care. What is the purpose of this legal framework? It provides a very good legal, clear document which protects both the patients as well as the healthcare providers' rights. And the example of it, few example of it is basically the Indian examples. The Supreme Court of India in 2018 had recognized the legality of passive euthanasia and living wills under the strict safeguards. Another example is guideline by Indian Council of Medical Research, that is ICMR, on do not resuscitate orders in palliative care. So these are certain legal frameworks which are already present in India and followed in India, which we as a healthcare provider should know. Then coming to the end of life decisions. What are the end of life decisions and what are the ethical debates what we face in these decisions and what can be the legal status of it in India. It is again very important now. We all know what kind of care we have to give in end of life or what are the important or conflictable decisions which happens in this stage of life. But then again, we have being a healthcare professional, we should know the legalities of these decisions and we should know what kind of decisions can be taken in these situations. So the definition of euthanasia is it is intentionally ending a patient's life to relieve the suffering of the patient, usually by a physician administered lethal substance. So it is also known as assisted suicide, like providing means for a patients to end their own life. Now, what is the ethical debate which goes on when it comes to euthanasia? It is there are supporters who argue it and respect the autonomy and relieves the unbearable suffering. Like there are supporters who believe that it is a good thing that a patient, if he thinks that I do not want to suffer more from this illness and I want to end my life, so there are people who support these decisions, but there are also opponents who oppose the idea of euthanasia. They argue that it violates the principles of non-maleficence, that is, do not harm, and it could lead to misuse also. So, what is the legal status of it in India? So, it is illegal in India except passive euthanasia under very strict safeguards. So, active euthanasia is not legal in India. Only passive euthanasia in certain conditions, that too under strict safeguards, are possible in India. Yeah, but euthanasia is legal in some countries like Netherlands, Belgium, Canada, and some parts of US states also. The example is in India, a patient with end-stage motor neuron disease cannot legally request euthanasia but can refuse life-prolonging treatment and opt for palliative care. That can be a kind of passive euthanasia. The next end of life decision, which is again very important, is palliative sedation, that is legal and under the legal and ethical boundaries. So what do you mean by palliative sedation? So the monitored use of medications like sedatives to intentionally lower the patient's consciousness to relieve intractable suffering, or that is a severe pain or agitation or breathlessness when other treatment fails. That is known as palliative sedation. Now, what are the ethical boundaries when it comes to palliative sedation? Basically, the goal here is to relieve the symptoms of the patient and not hastening the death. We are not taking the patient towards death, but we are trying to relieve the suffering of the patient by this. It requires the informed consent from the patient or the family member of the patient if the patient is not able to take the decisions, and we have to document it, and it must be distinguished from euthanasia as the intent of doing palliative sedation differs from euthanasia. What are the legal aspects here? Generally accepted worldwide as a part of palliative care, so it is accepted all over the world. And in India, the ethical guidelines of ICMR recommend strict monitoring and documentation. So it is legal in India, but then when we are doing or following palliative sedation for any kind of patient, we have to do very strict monitoring and documentation of this procedure when we are doing it on a patient in India. So example of it is a patient with terminal lung cancer and uncontrollable breathlessness is given palliative sedation to relieve the suffering in the last days of life. So rather than suffering from breathlessness and pain, we give them sedation so they lie in a they are lying peacefully. Then the next end of life decision here is withdrawal of artificial nutrition and hydration. So what is it? It is stopping the life-sustaining measures like feeding tubes or IV fluids when they no longer contribute to recovery or quality of life. So we basically stop their artificial nutrition here. Now, what are the ethical considerations which we have to consider here as a healthcare professional is ethically acceptable when the artificial nutrition and hydration prolongs suffering. So if it is prolonging the suffering of the patient, we have to it is ethically accepted in India, and it should be based on patient's prior wish, whether the patient has given any prior directives that if it is only prolonging my suffering, then my artificial nutrition and hydration should be stopped. If they have given such kind of prior wish or the surrogate has given any kind of such decision, then only we can take this kind of decisions. Now coming to the legal aspect in India, withdrawal of life support is recognized under passive euthanasia as per Supreme Court's judgment given in 2018, and it also requires a medical board approval and legal safeguard to do so. So if you feel that will be no improvement on the patient and we can withdraw the artificial nutrition and hydration. So first thing is we have to take a medical board approval to do so, and it should be documented properly. The example here is a patient in a persistent vegetative state for years with no chance of recovery may have tube feeding withdrawal after family consent. So that can be a good example of this withdrawal of ANH. Now that was all about the legal issues. I hope you understand. Now the very important part when it comes to legality and legal and ethical issues in palliative care, the important point is also maintaining the rights of the patient. So for that you should first know what are the patient's right when it comes to palliative care. So the first right of the patient is right to pain relief. We all know what does it mean. It means that every patient has the right to receive an adequate pain management treatment to relieve from the pain. The importance of this right is pain controls and improves the quality. Pain control improves the quality of life, and it also preserves the dignity of the patient and reduces the suffering of the patient. The example of it is if there is an advanced bone cancer patient, he receives morphine for the pain management which is having. The second right of patient in palliative care is the right to dignity and privacy. Now, what does this right to dignity and privacy means? So it means patients should be treated with respect, compassion, and confidentiality, especially during the vulnerable stages of illness. So confidentiality is very important here. We have to maintain the dignity of the patient and confidentiality of the patient data. That is our important role over here in this kind of patient's right. The importance of it is preserving the dignity ensures that the patient are not reduced to their disease but are recognized as a whole person. We are not looking at the patient just as a patient but as a whole person. We are giving him a care as a whole. The example here is allowing a terminally ill patient to spend their last days at home with family rather than in an ICU with invasive procedures. So that is the example of it. The third right is right to refuse the treatment, wherein the patient have an autonomy to decline to the treatment, and he can also refuse the treatment which may hasten the death. Now, what is the importance of it here? It respects the self-determination and prevents unwanted or burdensome interventions on the part of the patient. Example of it is a patient with terminal heart failure refuses the mechanical ventilation and opts for comfort care only. So that is the example of right to refuse the treatment. And the next right of the patient here in palliative care is right to information. So what does it mean? It means that the patients are entitled to be fully informed about their diagnosis, the prognosis of their disease, and the treatment options in clear, understandable language. We have to tell them everything, whatever is there. It will enable the informed decision making and enhance the trust and reduce confusion for the patient by taking the decisions. For example of right to information is a doctor explains to a patient with advanced cancer that further chemotherapy is unlikely to cure the disease, but that palliative care can improve the quality of life. So this kind of information we can give to the patient based on which the patient can take their own decisions about the treatment. So these are the patient's right which plays a very important role in palliative care. So that was all about the legal ethical issues in palliative care. What is palliative care? What is the importance of palliative care? Why do we give palliative care to the patient? What are the legal issues which we can face during palliative care? And what are the ethical considerations which we as a healthcare professional has to do while providing palliative care? All of this we have seen now. Now let's see what is the role of healthcare professional when it comes to palliative care. So the first role is ethical duty to advocate for patient. So healthcare provider must speak up for the best interest of the patient, especially when patients are vulnerable, in pain, or unable to express themselves. So basically we have to do the advocacy here, which will ensure that the patient receives appropriate care, respect for their rights, and relief from the suffering. So we have to talk for our patient and for the rights of our patient here. So the example of ethical duty is like I'm giving you example of each and every point so that you should understand wherever these points are applicable, right? So example of ethical duty to advocate is a nurse ensures that a terminally ill patient receives adequate pain relief even if family members underestimate the patient's suffering. So sometimes we see that the patient is in pain and telling again and again to the family members that I'm having pain, I'm having pain. The family members are not really taking it so seriously. But being a nurse, it is my duty to take the symptom of the patient seriously and provide him some pain relief medications. So that is the ethical duty to advocate for patient. The next role is managing conflicts between the family and patient wishes. So it also again sometimes happens by taking decision. Sometimes the patient doesn't want to take the treatment to hasten his death or to he doesn't want that suffering to prolong. But at the same time, the family members want to take all available treatments to save the life of the patient. So this kind of conflicts can be seen between the family members and the patient. So here we have to often ethical practice requires to respect the patient's autonomy, while we have to again understand the family members also and we have to support them also. But we have to basically look at the patient's right of autonomy here to take his own decisions, and we have to explain about it to the family members and we have to support them. So the example of it is a patient with terminal cancer refuses the life-prolonging ventilator support, but the family members insist to have it. So here, what we have to do as a healthcare professional, we have to facilitate the communication and we have to support the patient's decision here, and we have to make the family member understand about the decision. The third rule is interdisciplinary team approach. So palliative care is most effective when doctors, nurses, social workers, psychologists, and spiritual counselors work together as a team. Not just a doctor or a nurse cannot provide palliative care, right? It is a team effort. So this approach addresses not only physical symptoms but also the emotional, social, and spiritual needs of the patient. So example is a patient with end-stage illness receives pain relief from the doctor, counseling from the psychologist, and spiritual support from the chaplain, ensuring the holistic care. So that is what is interdisciplinary team approach means. So that was all about the role of healthcare professionals. So there's a certain case studies wherein I just wanted to explain you the difference between the ethical aspect and the legal aspect. We all read it ethical and legal issues or legal and ethical issues, but there is a very thin line between what do you mean by ethical and what do you mean by legal aspects. So this is just an example to clarify that. So the example, the first case is the patient refusing a life-prolonging treatment. So what is the ethical aspect here in this kind of situation? We have to respect the autonomy of the patient. That is his right to decide whether he want to take the life-prolonging treatment or not. We have to protect the right of beneficiaries and non-maleficents here. That will avoid the prolonged suffering of the patient, and at the same time we have to maintain the dignity also of the end of life care. These all things will come under the ethical aspects when it comes to the care of patient with palliative care. But what comes under the legal aspect here in the same situation is the patient with decision making capacity can legally refuse. He has the right to refuse to the treatment, and informed refusal must be documented. As soon as the patient refuses to take the treatment, we have to document this informed refusal of the patient, which comes under the legal aspect, so that later on we healthcare professional will not get into any legal problems due to the case. And another aspect here is advanced directives like living wills are legally recognized. So that can also be, taken into consideration in this kind of decisions. So that are the difference between the ethical aspects and legal aspects in this care. Another example of this can be family requesting continuation of futile treatment. Like the patient is into a vegetative state, there is multiple organ failure in the patient, there is no chance of patient to improve in future. In this case, what still the family wants to continue the treatment. So, what is the ethical aspect in this situation? Beneficiaries, that is, futile treatment causes more harm than benefit. That is something which is we have to consider here. Justice, that is misuse of scarce medical resources, and respect, like you are using the medical resources already, we have shortage of medical resources and we are using it for a patient where we know that it will be futile, there will be no use of this treatment for this patient. And another point here, what you have to ethically consider is respect emotions but prioritize the patient's best interest. We have to respect the emotions of the family member who want to continue the treatment, but at the same time, we have to we have to prioritize the patient's best interest also over here. Now, what are the legal aspects here in this? So the legal aspect here is doctors are not legally obliged to provide any kind of futile treatment. We can withhold or withholding or withdrawing futile treatment is lawful with proper consent. So we can do it, but we have to take the consent before doing it, and we have to do an ethical committee review for taking such decisions. And the best interest principle also guides decision, not only family wishes. So though the family wish to get the treatment, but the best interest principle about the for the patient talks that any kind of treatment which will prolong the suffering of the patient should be immediately stopped. So these are the two case studies wherein I tried to explain you the difference between the legal and ethical aspects and the legal aspects. Now, what are the challenges what we face in India when it comes to legal and ethical issues in palliative care? So the first challenge is lack of awareness about the palliative care rights. Patients or patient family members does not know what are their palliative care rights. So we have to, the patient and family often do not know about their rights. So that is one of the challenges in India. We as a healthcare provider has to make them aware about their rights. The second challenge what we face in India is limited legal clarity about the end of life decisions. Nobody have the legal clarity about this decisions, what kind of decisions can be taken in which situation. That is another